Well, I thought like 10 minutes ago. When we start, you can join in. That's okay. Yeah, just. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. صباح الخير. أهلا وسهلا في هذه الجلسة. Genetics and pharmacogenetics and how to optimally implement them in psychiatry. It's a great pleasure organizing this session. It is something that at WPA meetings we have been doing now for that's the second time. The interesting aspect of this is that WPA is involved in a major European Union grant, and we'll hear about this in a little while. And WPA is a recipient of a grant money to organize educational sessions like this. So it's a real privilege to put together a session like this and to educate and to engage in a discussion with clinicians all over the world to discuss the benefits or the potential benefits of genetics and pharmacogenetics. So we have put together a panel of international and here local national experts to discuss this topic. And it's my great pleasure of introducing to you the panelist. One panelist is still missing, but I've seen him, I just saw him 10 minutes ago, so maybe he hasn't found the room. But so we have distinguished speakers. I'm starting from over there. Smita Deshpande, Professor Deshpande at the Department of Psychiatry in St. John's National Academy of Health Sciences in Bengaluru, India. She is the co-chair of the WPA genetics section, and she has been a leader in India in the genetic research of mental illness, and with a emphasis also on addiction. So then Marcella Rietschel is the department chair of the Department of Genetic Epidemiology of the Central Institute of Mental Health in Mannheim. She's professor at the University of Heidelberg. She's a national and international leader in psychiatric genetics. She has published more than 600 papers on all aspects, and she has a particular interest in the ethical, legal, societal issues of genetic research. Then we have Dr. Rose van Westrijnen. She's an assistant professor and psychiatrist and clinical pharmacologist in Amsterdam, but also professor at the faculty of the University of Maastricht. She's a senior lecturer at the University College London, and she has been for many years a leader of pharmacogenetics in psychiatry in the Netherlands. I would like to call her maybe Miss Pharmacogenetics in the Netherlands. She has brought pharmacogenetics and psychiatry to the Netherlands, and she's the scientific coordinator of this European Union grant that we will hear about in a second. Oh, Hamid just arrived. It's a pleasure. Hamid Al-Hajj is a consultant psychiatrist, head of the Department of Family Medicine and Behavioral Medicine at the University of Sharjah. He's director of research for the National Association of Psychiatric Intensive Care in the UK. And so we are pleased to have him here as well as a representative for this country and the region. Then we move on to my dear colleague, Maha. Professor Maha Mohammed Sabaiyat is professor of pharmacology at the University of Sharjah. She is involved with the Emirati Pharmacogenomics Passport, and she has done many studies not only in psychiatry but in many other disorders and aspects of human health, and is involved in major Emirati projects, among them also pharmacogenomics of asthma medications. And last but not least, it's a pleasure to welcome my dear colleague Fernando Goes. Fernando is associate professor of psychiatry at the Department of Psychiatry at Johns Hopkins University in Baltimore, Maryland. And he is, Marcella is the chair of the section, and Fernando is the secretary of the section on genetics. And he has been involved for many years with the genomics of mood disorders. So, and now I would like to hand over for the scientific moderation to my dear colleague Marcella Ritschel, the chair of the genetics section, and she will then go through the program. Thank you, Marcella.
Thank you, Thomas.
Later, I think we can also
I have to usher you down, except for Fernando Goes, who will now present about the genetic of psychiatry. And we only have 60 minutes. You can imagine it's such a huge and promising field, and we want to make it as short and focused as possible that you get a glimpse what genetics and pharmacogenetics can bring forward to the wealth of our patient. And actually it is planned that you can ask your questions, because we are all specialists, we know what we are talking about, but it is important for you that you can ask the questions you want to ask, and therefore I will very much push my colleagues to keep in time that you have the chance afterwards to ask the question. So first I would like Professor Fernando Goes. Where is he?
Behind you?
Okay. They are always quicker, yeah, to start.
Yeah. Thank you. Okay. Excellent. Turn on. On. Okay. Excellent. Good morning, everybody. It's a pleasure to be here. I am tasked with talking to you about psychiatric genetics in all of 10 minutes. So hold on to your seats. But as she said, we are all here during the conference. So if you have questions, please ask them at the end or any time during the conference. It would be a pleasure to be involved. So our current status quo, of course, in psychiatry, but also in the rest of medicine, is that we live in this sort of land of imprecise treatments. We do have treatments for essentially all our disorders, but they're not as good as we would like them to be. So the effect sizes, for example, for the antidepressants, are usually around 0.3, which is moderate. So certainly they work. They always generally tend to show significance in clinical trials. But ideally, at the individualized level, you want bigger effect sizes. So how do we improve on our status quo? Well, we can be lucky, and we have been lucky. We've discovered many things with good observations, such as the antipsychotics, lithium and ketamine, for example. But ideally, we want to understand the underlying pathophysiology, any aspect of the pathophysiology, the pathogenesis, or the pathophysiology itself, to discover novel medications. And this is where we get excited about genetics, because if you don't really know where to start, nature gives you the clue. And the clue is really heritability. And all of our major psychiatric disorders are highly heritable, some more than others. So schizophrenia, bipolar, higher, depression, PTSD, alcoholism, lower, but still significantly heritable. Now, does high heritability necessarily mean that it's a Mendelian, a quasi-Mendelian type of disorder? This has been a tough lesson, and the answer is clearly no. So these are highly heritable disorders, but they're very polygenic, so multi-causal. And I'll talk to you a little bit about how we handle some of, or understand some of that multi-causality. Why do we study genes? Well, genes should be the easiest thing. It's stable, it's easy to identify, easy to measure necessarily. We can now do it in very large sample sizes that are necessary if the effect sizes are small. And largely it's the same in any tissue, and that's a huge advantage, right? I can get your genetic code from blood, from spit, from saliva, from skin, any part of your body. I don't need to go to the brain to get what is actually representative of the brain. But ultimately, the genes are not really the action, where the action happens in biology. That's more at the level of proteins, at the level of networks, at the level of cells. So when we think about genetics, and you think about some of the association in genetics, remember that genetics comes first, which is a big importance in terms of causality, but that they're very far away from our phenotype of interest. So our major study in genetics is what's known as the genome-wide association studies. So these are studies of common variants across the genome. And it's a very simple design necessarily. It gets complicated because of the numbers involved, but ultimately you're using something such as a chip, shown there, and you're measuring many places in the genome where you know what the variation is. You know that you have an A or you have a T there, for example. You know that from before. And you're just looking at frequency differences between cases and control, and that's really just what a GWAS is. It's essentially a chi-square test. It's a little more complicated. You get an odds ratio, you get a p-value, and of course, a lot of the hard work is controlling for potential things that may go wrong, but that's sort of under the hood. But ultimately, it's just a single chi-square test looking at frequency differences, and you're looking at it in one marker, but you're genome-wide. So essentially, you're looking across the chromosome, across all your chromosomes, and you're just going one by one by one by one. It's very rote type of analysis, but it's very simple. And ultimately, what you want to see is that there's one region or a couple of regions that have very small p-values. Here, if we do a minus log, we're reverting it to make it a little bit easier. And this is what's known as a Manhattan plot, which is how we show many, many associations, simple associations, like I said, but just across the genome in one figure. And the message has really been that you need to collaborate. You need to collaborate because you need massive sample sizes, and that's much larger than one group, than one country, than really one region can do. So the story of success of genetics and psychiatry has been this issue of collaborating and putting multiple groups together. And that will be a story that will, of course, be important for pharmacogenetics. So in 2011, after many years of each groups doing their own things, this is probably hiding 10 years of groups doing their own things and not finding anything together. Things were put together within a consortium, and there were the initial sort of hints of an association. And then every few years, more and more cases and controls get accumulated, and the results get stronger and stronger, right? So 2019, this is, I was going to say the most recent is 2022, but there's actually not yet published an even larger genome-wide association study. So, for example, this is in bipolar disorder, and you can see why it's looking like a Manhattan plot. But of course, you can also call it an Abu Dhabi plot, which is ideally what you want. You want these very tall peaks, and you want the genome to be relatively low, because now what we want to do is really hand this off to sort of more biologically inclined colleagues to study what's underneath here or what the biology is. And here, for example, in Abu Dhabi, you'll have 6 or 7 really nice peaks. What we're finding, though, is actually it's more like a Sao Paulo plot, which is just there's tons and tons of concrete everywhere. It's a bit disorganized, every part of the genome. In a sense, GWAS has gotten too good at finding associations, right? So you increase sample sizes and you essentially get significance and many, many associations of significance in all your disorders. If you look at the bottom, you can just see that all the major psychiatric disorders now have well over 100 GWAS associations. So a little bit too much to handle, right? From zero, we got to a point that there's just a lot to handle and it becomes very complicated. So what do you get from a GWAS? The nice thing is once you hit that genome-wide significant threshold, you're pretty confident that it's going to replicate. Not 100%, but close to 100%. The associations, though, are pleiotropic, meaning that they're associated with many phenotypes. That's just been more of a rule than an exception. So it's rare to find a gene for schizophrenia. It's a gene that somehow leads to a neurobiological subtle dysfunction that's often associated with many phenotypes. You get initial inferences about potential pathophysiology, and what I'm most excited about is you get to identify or provide initial support for targets for novel drug discovery. So can we use GWAS, for example, in the clinic if you ever see a genetic test looking at a GWAS association? And your answer is really a big no. And the reason, for example, look at the bottom here, I'm giving you one of the top hits in bipolar disorder in this calcium channel gene, is that you find this risk allele in 34.5% of cases, but the challenge is that you also find it in 33% of controls. That's why the odds ratio is so low. That's why you need such large sample sizes, okay? So tiny sample sizes, but the reason I don't despair and the reason you shouldn't despair about GWAS is that it really can identify drug targets, that we have a record of identifying drug targets with GWAS that have turned out to be clinically useful. So 2 examples here in cardiovascular disorder are the statins as well as the PCSK9. Okay, So if everything is small, one of the other things that we can do is just add them up, right? Add up lots of small effect sizes. And we do this based on essentially just adding up the markers and deriving what are known as polygenic risk scores. So simplistically, polygenic risk scores is simply adding, do you have the risk allele or not? And add it up in cases, add it up in controls. Sure, there's some weighing, but the method is just about adding it. And what you see is that almost inevitably, this is again something that replicates tremendously, is that cases have slightly higher than controls. Whoops, sorry, this had a beautiful curve here where you'd see two overlapping curves a little bit like this. And I was going to show you that this is one very famous overlapping curve that you all have seen in medical school or in clinical practice. And does anybody know what this is? Does anybody remember from medical school? So this is cholesterol, right? So this is the ability to use cholesterol to predict heart disease. And you can see that there's a tremendous amount of overlap, but still this is something that has clinical utility in medicine. And so when we think about the overlapping, more or less what we're aiming for is on the left side. So there will always be some degree of convergence, but there will be some degree of also of separation. And of course, if you're in the middle of some of those curves, it's not going to be particularly helpful in terms of discriminating one phenotype versus the other. But if you're in the extremes, it will be much more informative for example, precision medicine. Okay, so that's common variants. I'm out of time, and this was my only slide on rare variants. I'm happy to talk about rare variants. It's in a sense very similar. Typically, they have higher effect sizes, not necessarily, but it's another type of discovery in genetics that we use sequencing for, and not so much the chips. But I only have 10 minutes, and as I said, I'm happy to speak with you about any of these sorts of things. So I call it's a mature field. We have a sense now of what's going to replicate or not. We have a sense of how to do these studies. We didn't necessarily 15 years ago. It was a very unstable field. From my view, the primary goal is to yield biological insights. I see genetics as a common baseline for personalized medicine. That is, I don't think genetics by itself are going to be enough for personalized medicine unless you're an unusual outlier. So for example, somebody with autism that has a common variant or a very large-scale deletion. As in all things in life, diversity matters a lot, right? It matters in terms of better science, because for the next steps in genetics, in terms of trying to understand the individual loci, variations amongst population is very important to help us understand that. So the major thrust now in psychiatric genetics is to collect more diverse samples. And GWAS now is dirt cheap. It's the easy part of genetics. We've turned it around. What's actually challenging now is to do the phenotyping at scale, particularly what I call phenotyping of clinical relevance, right? So prognosis or drug response. So lots of work has been done, lots of work to do. If you're at all interested in this topic, we do, of course, in WPA have a section, so please join us. Feel free to email me, and I will pass the baton. Thank you. Oops.
Thank you, Fernando, for this very impressive talk. Everything was in there, and I hope it is recorded, though you can hear it another 5 or 10 times. So I asked now Smita Deshpande to introduce you in the genetic of pharmacogenetics, because this is something which can already be used, but it is still very tricky, and she will give you a short overview about the field. Smita.
Assalamu alaikum. Namaskar. Namaste from India. And as a clinician, today I'll be talking about what is pharmacogenetics, just opening up the topic for you and introducing you to what you can do in the clinic. Because as mental health professionals, our main goal is to deal with patients and to give them a better life. So let's see how pharmacogenetics can help you do that. Not this one. This is not my presentation. And does it have a pointer? Right. Just a moment. And Marcella, I hope you won't count this time towards mine. Yeah, this is the one, right? So let's talk about what we as clinicians need to know about pharmacogenetics. Primarily what it is, first of all. Now, as clinicians, we know that we have a lot of variations in response to drugs. And no matter how many guidelines we have, much of our practice is almost like hit and miss. So, which is the group we like the best? We like this green group the best because whenever we prescribe a drug, these guys, they respond beautifully, the drug shows great efficacy and there's no toxicity and he comes back very gratefully. This group, it's a little iffy in the sense that they have efficacy, but they might come back and say, you know, we have these problems, that problems, and you may not be able to continue the medicine. These bottom groups are more difficult because one group may not have any toxicity, but they may as well have no efficacy either. So you are still at a standstill. And this is the worst group, the red traffic light group. There's no efficacy and no toxicity. And yet, for a clinician, this entire group is the same. They all have the same diagnosis, and we all start with the same medications with these groups. So, what could be the reason? There are multitude of reasons. That's what Fernando also was speaking about. And that's why we have to have so many samples, so many GWAS and samples from across the world. One of these reasons is genetic variation. Because you know, genes are the building blocks of life. That's what we learned in our school. So, genetic variation can account for a lot of variations in efficacy in a lot of drugs that we use, not only across the counter, but with prescription also. And that is what our effort is, to try and make medicine more precise so that we can give the drug that will best suit our patients, and everybody will show us a green light. Everybody will have efficacy without any toxicity. So what are the tools that we can use? Well, one of the tools is pharmacogenetics, because as Fernando again said, that pharmacogenetics deals with how genes impact on the drug response. So when we study drugs in the human body, we look at pharmacokinetics, which are transporters and metabolizing enzymes and CYPD and all these enzymes. Or we can study pharmacodynamics, what the body does to the drug, how the responders, receptors, transporters, enzymes in the human body react with the drug. So essentially speaking, if we look at a definition, pharmacogenetics is how genetic differences affect variations in the response to medication, any medication and any disease. So for that you need a very clear understanding of what the disease is, the diagnostic features and so on. Maybe you need a biomarker which could pinpoint that this is the disease that you are tracking, and you also need a good medication. So why do we need pharmacogenetics? Apart from everything, we have huge clinical samples, we have guidelines for everything, and they are repeatedly revising these guidelines every year. Basically, our current treatment are not satisfactory, essentially. Almost up to 50% of our patients with depression may relapse. Hardly 1/3 of many of our patients respond. Many of them go off the drug because they simply couldn't tolerate it. So that is clearly an unsatisfactory response for a clinician. I won't go into the details. I know that these are big studies, but they are large studies, and they are still being worked on. The results are still coming out even now, and that is why I quoted them. So what could be the solution for this problem? One solution could be pre-prescription genetic testing and personalized medication therefrom, which could offer some kind of a solution to our problem. In fact, in the last 10 years, even the US FDA has approved several genetically pre-screened drugs, and it has labeled them as pharmacogenomics in the field of oncology, pulmonary medicine, and even in psychiatry. So, in fact, genetic testing and genetic markers are now routinely used in many cancers and even in many infectious diseases. But as far as we as mental health workers, as psychiatrists are concerned, the FDA table of pharmacogenomic biomarkers in drug labeling includes a number of very popular drugs, and we can see some of their stalls right outside. That includes aripiprazole, atomoxetine, citalopram, clozapine, fluvoxamine. I could go on. You can see the list here. So that brings us to what types of pharmacogenetics can we, what kind of pharmacogenetic studies can we do? So the one type of study is safety pharmacogenetics to prevent adverse drug reactions, and the other one is efficacy pharmacogenetics to predict response. And many times we are more worried about not having an adverse drug reaction rather than having an effective reaction. So mostly we have pharmacokinetic targets, how the drug travels in the body and what kind of things happen to it as it goes through the body. But unfortunately, the Asian data is very sparse. So we as clinicians, first of all, need to learn how to interpret gene mapping reports, because at least in India, we are having increasing commercialization of GWAS, and there are lots of ads which tell you that, just send us your saliva sample from your cheek and we'll give you your whole genetic birth chart, the Janam Patri. So there might come a day when we all get it done just for fun maybe, or just to keep a record. So as clinicians, when our patients come to us and show us this little report, we need to know how to read it and how to interpret it as far as pharmacogenetics is concerned. So we need to know what could be the, in a study, when we find out the results, we need to know what is the odds ratio, what is the odds of the patient benefiting from that genetic profile or not, what is the level of statistical significance, have these studies been replicated in different samples, and is there some kind of plausible biological explanation, or is it just a noise, just a chance finding, which could happen when we have these huge samples, and much of it could be just, I'm sorry to say, noise. So what we need to do in our day-to-day practice, we can also contribute, each one of us. We need to, first of all, refine our area of interest. What is it that we want to work with? Depression, schizophrenia, ADHD, autism, whatever it might be. And improve our own reliability of diagnosis, improve our own record keeping, improve the validity of our diagnosis, maybe by checking it out with questionnaires or scales, and have those scale records in our clinical samples all the time. And then enhance the utility of our work. This will all also enhance our clinical acumen and increase the utility of our own work. At the same time, we need to develop adequate clinical skills for our clinical care by looking, when your patient comes with that little report, discuss with them. Have a good discussion if in case you want to have them to do their genetic testing. At the same time, be aware of what are the benefits as well as the limitations of such testing in that particular population. And I know that in the Indian population and in the Middle Eastern population, there's very little representation in pharmacogenetic studies. So we need to know what are the limitations of our science as well. When a patient asks, okay, do my blood test, doctor, to give me a drug. So you should be able to tell them what could be the benefits and the limitations of a particular prescription. And then finally, if you think that particular test is not very relevant, then be able to convince your patient that further action may not be advisable, may not even be necessary. So what we need to do is also on the scientific front, we need to collaborate to gather large samples, to incorporate pharmacogenetic testing in each of our research studies. We need to do the research to detect heterogeneity in drug response as an outcome measure, develop algorithms that incorporate multiple biomarkers, and RDoc could be a good sample to think of this. We need to enhance collaborations between clinicians actively, nationally and internationally, and supplement this with bioinformatics and the bench workers, who are most important, the geneticists, the lab workers, and so on. And then, of course, we back to our expert consensus guidelines. We need to have expert consensus guidelines for the use of pharmacogenetic information in prescribing to all the relevant groups. Otherwise, we are in danger of falling prey to various industrial concerns which may or may not benefit our patients. So, personalized medicine for psychiatric drugs is already commercialized, but the science behind that commercialization has still some way to go. So, we need to conduct studies as well as read studies and understand them to be able to keep up with all the information. Thank you very much. I hope I'm in time. And sorry for rushing through. We are all very rushed for time. Please ask your questions later.
Thank you very much, Smita. Now, Professor Deshpande pointed out all the very needs and what is to be done. And now it's a pleasure to invite our and your colleagues from here, local colleagues, but who are not acting only locally, come already along, but I advise you to read their very, very good review. It has many pages, it is very dense, it has appeared in 2022 in Molecular Sciences, and they will now point out what is already being done here, and thank you very much.
Thank you very much. Vielen Dank. Thank you very much, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to be here in this amazing conference, and thanks for the invitation, Prof. Schulz and the organizing committee. And in turn, I'd like to welcome you all here in the beautiful city of Abu Dhabi. So today I'm going to share some ideas about the implementation of pharmacogenomics in the UAE. I'll share it with my dear colleague, Dr. Hamid Al-Haj. And to start with, we try to have like a model of implementation of pharmacogenomics in the UAE. And it's just like in any situation and context, we have to reinforce the pharmacogenomics teaching in our curricula in the medical education. But of course, this will take a generation to be, to find an effect. That's why we have to accelerate things a little bit. Then we will reach at a point adopting pharmacogenomics, but in order for it to be sustained, we need to support it by clinical research. And we need also to find out the resources that will allow us to implement pharmacogenomics. So with each point, we have like an accelerating factor. So the implementation of pharmacogenomics in medical education should be supported by standalone courses as well as like disseminated knowledge of pharmacogenomics across the curriculum. For building the critical mass who are believing in pharmacogenomics, we have to train the clinical pharmacists and also to introduce the concept to psychiatrists in practice. We have also to make sure that the evidence of the cost-benefit of pharmacogenomics is clearly explained to the policymakers. And this is can't go without research. So the clinical research here is important. And hopefully, this will allow us to get this big issue of the costs of testing covered by the medical insurance. So what do you think, Dr. Hamid, about the clinical practice of psychiatry here in the UAE and the possibility of introducing pharmacogenomics? Do you think that is it's a near reach?
Thanks very much, my dear colleague and friend, Prof. Maha. So I'll move on to the psychiatric practice in the UAE. I have been asked to speak about this. I've worked in the UK for nearly 20 years and moved here around 2.5 years ago. So these are my 2 points of comparison. And as you know, psychiatric disorders worldwide are very common, very prevalent. They are a cause of major burden on the individual, on the society. They're associated with high levels of morbidity and mortality. And we do know that, for example, depression, it's very common worldwide. The data from the UAE would vary between different studies, and I think the explanation would be based on which sample that you've studied, but also which tools you have used. So we're talking about around 1 in 8 to 1 in 4 people with a risk of major depressive disorder. So the ideal situation, the clinician's hope and aim is to prescribe the medication for your patient that's safe, that's effective, that's not going to cause any side effects. Unfortunately, that's not always the case. And if I am to make some comparison, in the UK, a lot of straightforward depression and anxiety disorders are treated at GP level, that's family physician. So the secondary care psychiatry, we were left to deal with more complex cases as well as severe and enduring mental illnesses like schizophrenia spectrum disorder. The situation here is different, and I think yesterday's talks about building the primary care system in the UAE was very helpful and enlightening. In my current practice, I see lots of straightforward major depression, straightforward anxiety disorders, and they do respond generally to psychiatric medications. The variations, the problem with the variations, and I think it's the diversity of the UAE population. We have around 90% of the population are expats, and that would add, of course, pressure if you're thinking about what would work for certain population. I can think of some examples. I was sitting in a clinic, very busy outpatient clinic, with a couple of students, medical students, who also study with me in the medical college. And I didn't have much time to explain to them after each patient. And I happened to have a number of patients coming through saying, "I'm doing so well. Thank you very much for stopping my Cipralex. It was causing sexual side effects. I am absolutely fine. Can you give me the repeat prescription of Brintalex?" And that was okay. The second patient came and said, "Thank you so much for starting me on Cipralex. My sex life has improved so much." And,
No consensus.
and can you just repeat my prescription of Cipralex because I know you're busy and in a hurry. And then kind of later on, the student said, "Are you running a kind of a sex clinic or what, here?" Because, but I think in practice we see that. We see that side effects generally are different between different people. So what we aim for is precise or precision psychopharmacology. Of course, my previous colleagues have mentioned about pharmacogenomics and SNPs, and so I'm not going to elaborate on that at all. But what I would like to say that in the UAE, in the current practice, there are certain clinics that they do use genetic testings. Can I ask here, do you use genetic testing? Yeah, how many people? Yeah.
From the UAE.
Anyone from the UAE? Anyone from the Gulf region? Yeah? What's...
On dementia.
Oh, on dementia. Yeah, that's different. Yeah, that's very interesting. Yeah. Thank you. So I think Beautiful Mind, Abu Dhabi, but there are some other centers, they use genetic testing. The problem is that we don't know what exactly has been used, because it was mentioned that some of these are commercial, maybe some of them are evidence-based, some of them are not evidence-based. The cost is an additional problem for people. So I just want here to bring, and this is from our review that was mentioned earlier, that if we are thinking about the cytochrome P450, and there are variations, of course, between ethnic groups, but also between drugs and between, psychiatric drugs that we use. And for example, I had a patient who came to me and said she was on escitalopram, and she put a lot of weight on it. And she said, I don't want escitalopram, which of course makes sense. She was doing so well in terms of mental state, but she didn't want that side effect. And what I thought, if she's responding really well to SSRIs, why would I go to something else like SNRIs or any other drug? So I went for sertraline, and you can see that the cytochrome P2B2 compared to citalopram and citalopram, that the 2C19, and you see it's like different metabolism. So you do have people who have rapid or ultra rapid, people are slow, and so on. So I think that itself, and she didn't gain any weight on this medication. So I think it's to keep your mind open to what is available in terms of evidence, and try to reflect that on your practice. I'm hoping that soon we will have the data that we could say, at least for certain populations, what would be the appropriate testing that we should do. Prof. Maha and myself are running a study. From my clinic, I recruited 50 Emirati patients, and we are doing the testing. We're comparing them against Greek population. So I'll stop here and give it to my colleague.
Okay, so thank you very much, Dr. Hamid. And again, I can find the scattered pieces of the curricula dealing with the pharmacogenomics in different universities, actually in different programs. So again, there is a promise that we will have it happening hopefully soon, to implement pharmacogenomics with this level of evidence and education in our medical and pharmacy colleges. This is just an example of the introduction of different pharmacogenomic courses in undergraduate and postgraduate studies. However, without research, we couldn't prove our ideas. And fortunately, in the UAE, there is move towards cutting edge research in different areas. And we are really privileged by having good funding resources. So the two important projects that are now in implementation in the UAE University, the cardiovascular pharmacogenomics, and in our university, in the University of Sharjah, the pharmacogenomic passport for the Emirati population, which I'm leading together with many colleagues in bioinformatics and also in genetics. I try to divide this project into one in the psychiatry clinic, another one in the cardiovascular clinic, a third one in the gastroenterology clinic, and hopefully in the oncology clinic as well. So this gives us an opportunity to have some sort of flexibility and more clinicians to participate in such projects. This led actually to several publications. Let me just refer to the first thesis that was defended in the UAE University by a very promising and enthusiastic scientist and friend of mine, Zina Al-Mihiri. However, it didn't deal with the psychiatry medications. Another one about the awareness of pharmacogenomics among pharmacists. And actually, this interesting study by Dr. Azhar Rahma, again from the UAE University, it showed us that the level of confidence among clinical pharmacists is not that high. They believe in pharmacogenomics, but they do not think that they have enough experience and enough knowledge to implement pharmacogenomics. And another important study was published in 2020 on the screening of 100 pharmacogenes in hundreds subjects, normal subjects from the Emirati population. And this actually goes with targeted sequencing. In fact, we don't deal usually with the GWAS, as mentioned by Fernando previously, but we prefer to do the targeted sequencing, and we believe that this is much cost effective in terms of we have actually the experience on the Caucasian population, so why not to properly focus on those SNPs, on those gene variants, and try to find out if we have any close SNPs, maybe unique to our population, but still in the same region of the gene. So usually we are mapping the SNPs that have been already showing clinical evidence and clinical significance, and we are trying to go up and down like within an amplicon of like 200 to 300 nucleotides, and trying to fish for or explore if there are any variants unique to the Emirati population. We think this may actually create a good panel, as Dr. Hamid said, not only for the metabolism and the efficacy of the medications, but also for some important adverse effects that may be the main cause of the patient not compliant on his medication or her medication. This is actually our review article, and I hope that you will find it interesting. We discussed in it the ethnic variability, but even of global interest, the effects of the gene variants of cytochrome P450 on the neuropeptides, because they are also metabolizing the neuropeptides and not only the psychiatric medications. And to just find out or probe the awareness of pharmacogenomics, we carried out a study in the medical campus, finding out the perception and the attitude of our medical and pharmacy students towards pharmacogenomics. And in fact, they are very welcoming to implement that in the future. So we have promising future healthcare providers who are believing in pharmacogenomics. This will be presented in TUF, which is the toward Unity for Health. This is a big conference, will be carried out in the University of Sharjah next October, so I welcome all of you to attend it. And we are going to present our motto under many abstracts that is having this title, Precision Medicine for All, and how this is actually cost effective. So with that, I'd like to finish my presentation, and I hope that this will open discussions and hopefully future collaboration with all of you. Thank you very much.
Thank you very much, and for this valuable insights, and you only can be congratulated, and people in the UAE are probably ahead of everybody getting such good care. And as you mentioned, we should all collaborate because ethnicity and culture plays a big, huge role, and we need common recommendations. And this leads me to our last speaker, Rose, Professor van Westerlen. She is leading the hugest consortium ever, which is not industry funded, but pure science in Europe and the US, and she will give us a short update of this.
Thank you so much, Marcella, and also big thanks to the organizers of this conference. Great to be here, and thanks to the chairs also. I'm from the Netherlands, which is a very small country, but we started applying pharmacogenetics already in 1986 in psychiatry, and this is because there was a collaboration between a psychiatrist from a very big non-academic psychiatric institute in the Netherlands, in the east of the Netherlands, working with a PharmD. And this was one of the reasons, I think, why we have a long-standing tradition in pharmacogenetics, but also pharmacogenetics in psychiatry. And whenever I teach or I lecture, because I was a clinical pharmacologist before I became a psychiatrist, I always talk about the big three. And then I mean the mood disorders, the anxiety disorders, and the psychotic disorders. And these are the big three for me because pharmacotherapy is cornerstone in the treatment when it comes to the more serious forms of these disorders. And one has to bear in mind that when a person starts an antidepressant or an antipsychotic, in about 1/3 of people, this is, the right choice from the start. Because lots of people, of course, suffer from side effects, and there's also a problem with efficacy in lots of patients. So when people start, only 1/3 responds and can tolerate the medicines, and this leaves a lot of room for improvement, for sure. And this is something that I felt very, I took upon me, let's say, as a clinical pharmacologist. And I started to work on pharmacogenetics in psychiatry, and this is probably something you already know, but of course, when people take some medication, then most of the psychopharmaca are metabolized via the gut. So there's a peak level, and then the drug is metabolized via the liver. And we talk about, when there's a peak level and a trough level, and between these there's effects, then we call this the therapeutic window. And in this slide, you can already see, because of the time, I will click a bit faster. You can see what happens when people are, for instance, poor metabolizer for instance, CYP2D6, which is a very important pharmacogene for the psychopharmaca. Then you can see when a person is a slow metabolizer, it takes a longer time to reach the peak, but the peak is higher. And it also takes a longer time for people to metabolize the medication. And this means that people have higher blood levels and are more prone to have side effects. And you can also see in this slide what happens when people are ultra-rapid metabolizers. The peak is quicker, and the metabolization, the degradation of the medicine is also quicker. And these are the people that reach the lower blood levels, the subtherapeutic drug levels, much sooner. And there is a chance of undertreating those patients. And you can also see that the difference in blood levels between the poor metabolizers and the ultra-rapid metabolizers is tremendous. And of course, for most of the registrations trials of medication in general, but also for the psychopharmaca, this was not taken into account. Now, because of this long-standing tradition of pharmacogenetics in the Netherlands, and because we're such a small country, I think it makes for a good infrastructure. And right now, we have 16 hospital labs in the Netherlands where one can order, as a medical doctor, you can order genotyping for some specific genes, but it means that we can do it, and it's also reimbursed. It was not back when I started applying it in psychiatry, but it's been reimbursed since 2018, 2019. So it's what we do, let's say. Also, because there were already, you probably know, the people that know about pharmacogenetics, there's the Dutch Pharmacogenetics Working Group that formulated dosing advices based on pharmacogenetic phenotypes. And this was started in 2005. So already a long-standing tradition. And then there's, of course, the international pendant, the Clinical Pharmacogenetics Implementation Consortium, that was founded in 2009. And this is an international group, more US-based. And it's interesting because they are, like the Americans always are, much better in, spreading out news. So they have a very fancy website. But when you look at the specific dosing guidelines, they always refer to the Dutch guidelines. And there are not that many differences. I've been a part of the Dutch Pharmacogenetics Working Group for about 5-6 years now. And I was recently invited to be also a member of the CPIC to make sure that we align a bit more and there's not that competition, which is stupid. And of course, in order to implement in psychiatry, I took it upon me to set up a clinical guideline from without the Dutch Psychiatric Association. We started doing this 2015. And it took a long time to get the Dutch guideline authorized. It was authorized in 2020. And for this, of course, I reviewed the clinical evidence, so the prospective clinical trials in psychiatry. And they were all positive, and back then there were 7 clinical trials, but there was a publication last year from the Canadian colleagues, the Daniel Muller group, And now we have 13 trials in psychiatry, and almost all show a positive result when you apply pharmacogenetics and choose the medication and the dosage of the medication. This was mostly a positive effect on clinical questionnaires, of course. Not really looking into detail into side effects. Only a couple of studies did that. This is something that I translated for you. We published the Dutch guideline, which has now been referred to, I'm happy to say, I heard by the UK colleagues lastly, and also by some German colleagues. They called it the European guideline. That's great. And this is a figure that we prepared, and it's very simple, and also for psychiatrists that are always busy, it's very simple to work with. One has to bear in mind that still for lithium and for the tricyclic antidepressants, we still do TDM, and of course for the clozapine. But for the other drugs, we advise to do genotyping for only CYP2C19 and CYP2D6 in principle, and only when people have had problems before in terms of side effects or lack of efficacy. So not preemptive testing yet. We also published with the Dutch Pharmacogenetics Working Group and also updates on how to apply pharmacogenetics. This was a publication from a year ago on the SSRIs, and we recently published on the antipsychotics as well. I also started an outpatient clinic on pharmacogenetics in psychiatry, and I've been leading that clinic since August 2017. And I provide personalized medication advice for people that have a psychiatric diagnosis, they had problems before with psychopharmaca use, and I base this personalized medication advice partly on the pharmacogenetic testing, but also on the diagnosis, the medication history, co-medication and comorbidity. I make use of a pharmacogenetic passport. I'm very happy that you're also working on that over here. It's really nice because we have a passport that works with coloring. This is an example of, this is a test passport. So it's showing all kinds of genes, but basically I test for 2C19, 2D6. And what you can see, it works like a stop sign. It's really nice to tell the patient, green is nothing there, normal metabolism. Then there's the orange, which means the intermediate metabolizer status, so slightly less enzyme activity. But you can also have red, which is the poor metabolizer status. And there's also blue, the ultra-rapid metabolizers. Then Marcella also mentioned the PsyPGX consortium that I set up, and we're working on implementing pharmacogenetics in science. We're right now assessing the 7 Finnish biobanks and the UK biobank for proxies of clinical outcome and 2C19 and 2D6. We've started a clinical study which we're performing. It's based on my outpatient clinic. And we're performing a randomized clinical trial of pharmacogenetics in psychiatry in 9 sites in 7 countries, amongst which US. And we're combining all these data to set up an algorithm for medication prescription. And also we want to come to a new model of PsyPGX-based psychiatric care, we call it. The study is 24 weeks. We have 5 time points where we measure all kinds of things, questionnaires, of course. This is a picture from the research that's going on. So there are a lot of people doing research in pharmacogenetics and psychiatry, but real clinical implementation in psychiatry, I'm very glad to hear that you're doing that here in this country, but still lots of work, I think, to be done. And please email me when you have other questions that we're not able to answer right here. Please feel free, but I love when you come into contact with me. Thanks a lot for your attention. And maybe we still have time for some discussion as well.
Thank you very much, Ruth. And I have to apologize to the speaker as well as to the audience that it was such a rush, but you had the chance within 60 minutes to hear the world experts in these topics. And now it's your chance to ask. There are no stupid questions. You are, yeah, go ahead, yeah. Please come on. And there is no, is there a mic here for, yeah. No, that's fine.
Hello.
Yeah.
I'm Dinesh from India, and I've got 3 clinical questions for you. One is that the study of genetics is like studying the cold shell of the building. It has no relevance to us. We are looking only at the warm shell of the building, that is the ducting, the electrical circuits, and the interiors. That is epigenetics. Epigenetics is the flavor that we understand as clinicians. We'd like to have your inputs on the latest. I'll give you a very specific example. A young adolescent trying cannabis for the first time in Amsterdam or in India, developing acute psychosis. 10-15% do, 85% don't. Does the current understanding help us? Because that is where the intervention lies today. Telling this young adolescent that at this time it is age inappropriate for you. That's the first question. The second question is that we as clinicians are moving away from the classificatory system of ICD and DSM, which is primarily based on symptom aggregation, to understanding only the external phenotypes of impulsivity, compulsivity, aggression, etc. And in that sense, our treatment approaches also are changing. We are no longer looking on, say for example, a depression which is occurring at the age of 60 years as a behavioral variant of an FTD, or a depression occurring at an older age that now it is not neuroinflammatory anymore, now it is a neurodegeneration, and the role of antidepressants is almost over in this individual. So where does this science of genetics and genetics help us to fashion and refashion our treatments? Third is the very startling information which the professor from Amsterdam showed us about the use of pharmacogenetics, and the results are very startling. We live in a very poor country. I've had just 10 patients of mine who are treatment resistant, and for us, all of them failed to give us any meaningful kind of information. The only thing we had is patient is not responding. We wanted to put them on a drug like say venlafaxine, would respond or not respond. If you look at all the drug trials happening today for the vortioxetine and the others they're following, none of them are including pharmacological component at the beginning. So when I want to start a new drug which is under patent and extremely expensive, should I do a testing for that or no? Thank you. And sorry for the long questions.
3 questions. Yeah, very modest, but very good questions. So who wants to ask? Do you want? Yeah. Lois, yeah, with the last question probably.
Thank you very much for these 3 questions. First question, of course, when you talk about etiology of the psychiatric disorders, that's very difficult. These are multi-complex disorders, and there's of course the phenotype, and I'm sorry about the drugs in Amsterdam, I had nothing to do with that. But, so that is a different and more difficult question, I think, and we still have a long way to go there. But I think the sexiness, I want to say, but the attraction of pharmacogenetics for me, it's not about, also your second question, about different psychiatric disorders, it's only about the drugs. So we're not entering the discussion of overlap of symptoms and are they different, are they related to each other, the psychiatric disorders, I mean, but it's only looking at the drugs and the medication response. And this is much more simple, I think, and this is a way to really start. And there's also, of course, the dosing guidelines that are already available, and lots of studies that have already been performed that show that it has effect when we take this into account. But only having for the 2C19 and the 2D6 right now in psychiatry.
The second thing is that your question about epigenetics. We are, just starting with epigenetics, as you know, and we are still at a very preliminary stage. So as far as the science is going, it's going ahead. But as far as the clinical interventions are there, we need to still rely on our social colleagues and the social, psychosocial and other interventions that have been standing the test of time so far. So we might still have to work on the clinical pointer, rather than looking at pharmacogenetics at this stage, and work towards getting better samples and better projects through in our own population. And the same goes for the pharmaceutical company not giving any pharmacogenomics information for new drugs, But I know that they have been collecting samples and they have been trying to at least, get their feet wet in the pool of pharmacogenomics.
It's in the expertise of all the newly registered drugs.
Thank you very much. My name is Saeed Hussein. I'm a clinical pharmacist. My question is regarding drug use disorder. Why people have a chance to be addicted more than others? Is genetic play a role in this? And if there is a study going on or any UA or outside UA? Thank you.
As far as I know, there is no study going on this domain right now, as far as I know. However, it's very interesting and actually stimulating to do research. I think we are going to have more collaboration with our first results published. I think this will attract many clinicians and collaborators from different parts of the country. So I hope that this will work nicely very soon. I hope we can discuss that, inshallah.
General question.
Yes, statistically, many studies have looked at genetics of drug use disorders. Actually, I haven't just done seen myself, done many. They're all essentially moderately heritable, similar to depression, polygenic risks, but yeah. So at the individual level, we're not able to give you any specific information. Hope, but again, more research is needed. Is the polygenic risk scores are the closest that we can get to in terms of risk factors, who's going to be more likely to develop. But again, in something like drug use disorder, for example, these sorts of risk factors, we have to study, but they could be overwhelmed by the social risk factors that we know are very important. So if there's no drugs in your society, you're not going to use it. But in a society full of drugs, what creates some of that variance? Genetics will play a role, but that doesn't just say that it's far more important than we know. That's a sort of question of research is balancing all the risk factors and seeing what's most applicable.
I'm Dr. Prasad Rao from Hyderabad, India. My two questions to all of the panel is, pharmacogenomics, as we understand in terms of clinical translation into practice, is we are studying only the pharmacokinetics of an individual and trying to categorize into a low, middle, or a high metabolizer. Do we really look in the future, immediate future, in the next 5 years? Is there a pharmacogenomic testing which would help us in the responders versus non-responders? There are varieties of pharmacological agents. It can be lithium, it can be mood stabilizers, or it can be antipsychotics and antidepressants. How much do you see? And to Thomas, my specific question is, how much do you really practice in the Europe? Because in India, as I think my colleagues in India and these parts tell us, it costs us $50 per individual to get a test done. And probably we are doing wrong. We do for a patient who is resistant to treatment, who is not responding to the molecule. We know that we are only testing one component of it, but we are not testing the. So I would like Thomas to comment on that part too.
You want me specifically?
Anyone can answer.
So, thanks. I think this is a very important question. I think different countries have different fashions. So I work in Germany and the US. In the US, where right now in Syracuse, for instance, I know that many patients now demand tests, and then the doctors, there's no system. In many places, doctors basically just organize one of these commercially available tests, and the patients and insurance companies shell out like $1,000 for this. So very unsystematic. This is one thing. In Germany, it's still not, maybe not, it's not like the Netherlands. It's still more, trial and error, and then maybe at the third time it's not working, then you might think, why not do a test or so. This is, there's not yet a guideline really, or it hasn't really entered the clinical thinking of most psychiatrists, and that's what I think these studies that Rose is coordinating trying to accomplish. So that's just how I see it.
I just want to add some reflection from the field of oncology, because this is the other field, the cancer research, the other field that I'm working on actively right now. And for the field of oncology, in order to prove that those patients are responders or non-responders to a particular treatment because of certain phenotype of the cancer, it took like 2 decades in order to find out the targeted therapy according to the protein overexpressed from the cancer cell. So, in fact, in oncology, it is even easier because you have a direct readout. You are going to test to find out the overexpressed protein and prescribe the treatment accordingly. And again, this is also a form of pharmacogenetics because it deals with targeted therapy towards somatic mutations. In the context of psychiatry, I think it's very difficult because you don't have also that clear readout that shows the clear benefits of your tests. So it is multifactorial. It needs maybe the AI to be integrating all those factors. So artificial intelligence models can give us maybe a clearer view of how pharmacogenomics can benefit the utilization of tests.
Thank you, sir.
Next.
Can I?
No. The one who's...
Just a quick point. I think in clinical practice we see clinicians losing hope very, very quickly. One patient didn't respond to 2 or 3 medications. They start to think, maybe this patient is not responding. They start to add diagnoses, personality disorders, and so on. And I would like to say that the vast majority of patients do respond to medications. So at the moment we don't have like one size fits all, and I don't think we will have a one size fits all in the future. But I'm hoping that in the future it will not be as much of trial and error. But my message to practicing clinicians: never give up hope, because the patient will respond eventually to one medication or combination of medications.
Yeah. Your
Thank you very much for excellent presentation by all of you. My thing is, yes, it is a long way to go still, because whenever we are discussing the genetic studies in psychiatry, all the diagnostic criteria, as Dr. Rajesh Nagpal mentioned, is regarding the symptomatology. It is not the biological basis. All the diagnostic criteria still we have. So connecting the diagnosis and the genetic study is quite a difficult job. How can you? Because it is not depends on the biological job. And my second question is there any study which support the genetic studies, which support the who are susceptible to commit suicide, or any study regarding the suicidality or suicide with the genetic studies there still now?
Where we were planning something on suicide, and one of our studies that was conducted at my own center says that the maximum number of suicides, at least in the research population that we studied, which was a suicide attempt in the last 1 month, but non-life-threatening. The major number of factors were psychosocial, work-related or family-related or relationship-related. It would be difficult to talk about genetic factors in those, but yes, there are some studies which speak about genetic associations with the suicide attempt. But then some of them are ever suicide attempt, and some of them are, within the last XYZ months. So it becomes very difficult to pinpoint. And again, as usual, they are not from India, from the Indian subcontinent. So how much we can just de novo put them on the Indian population is difficult to say.
There's one older study from the Swedish group in post-mortem samples where they looked into the 66 phenotypes and they were able to show that people that committed suicide compared to people that died of natural causes were more prone to have a non-normal 66 phenotype also.
And may I add to your remark about the diagnosis that the genetic studies have well shown that the diagnoses are sort of, let's say, not precise, that there is a big overlap. And in the future, we have to take a totally different approach, taking all the different factors we were talking about now, the psychosocial, the genetic, all the factors together, and we have artificial intelligence. And I think this will be a new step in the future to bring these things together. And to the colleague who mentioned methylation studies, yes, these are important, but we also have to keep in mind that most of the changes in methylation are predetermined by genetics again. So it's rather the genetics who determine which sort of methylation we will show under a given experience. But all these very complex things will, we are making a lot of progress, but little can be translated at the moment. And this huge gap is a little bit frustrating. We are promising a lot, but cannot give to the clinicians. So just to have this insight.
Can I add one comment regarding this? Because I asked this question. You know that in the diabetes, we are in the student life, we are told that if you control your diabetes by the medications or insulin, there is almost no chance of nephropathy or other complications. But nowadays they are saying it depends on the genetics, the family history. If you control your diabetes, still there is a high chance of getting nephropathy or other complications of diabetes because of your genetics. So somehow I am a hardcore clinician. I have seen there are severe depression. They are not committing suicide, but mild to moderate, or there might not be any indications of suicide, but they committed suicide. So there must be some biological part related to this. That is why I asked this.
Yes,
Thank you.
yes. There's the next question, yeah? No.
Myself?
Yeah.
Najm Al-Falahi, London, consultant psychiatrist. I hope that the work will be part of a holistic approach, because our biggest challenge really is that psychiatry is moving to a mechanical approach. And when we are moving to mechanical approach, the biggest problem is that we are diagnosing depression, but we don't know the cause of that diagnosis. And I am sorry to say that nowadays our psychiatrists seeing 10, 12, 20 patients per day without having a real diagnosis and a real holistic approach. How can we integrate the work that you are doing into really treating the patients, not treating the symptoms?
I think this is the most important question, and we are way over time, and I would pass it over to Thomas, but I see Professor Asfal also wanted to add something. Professor Asfal, so we can take this question together, because you know this cannot be answered within a few minutes. Yes. Yeah? No, here, bro.
Well, thank you very much. I know that we are over the time. It's not a question, it's just two very brief comments. First of all, congratulations and many thanks to our section on genetics for organizing these sessions, and we are particularly having all these sessions in our regional and thematic congresses, which is a way forward in terms of making this particular topic more popular and more visible in the scientific programs. The second comment is that I think that the time has come that we have to bridge the gap between the science and the clinical side. And genetics is one of the best example where we can take the lead. I would offer to the section and to this group that WPA's educational portal, we can always have some modules specifically for the clinicians in simple language. If you would like to prepare some modules, we will be more than happy to add those modules to our educational portal, which is free to use. And number two, while we will be meeting in Vienna in few months' time, if this group could produce some brief booklet that how science can be translated into the clinical side in this particular area. Otherwise, what will happen is that until and unless we are not going to touch the clinical aspects, the psychiatrist and psychiatry will stay away from science. So these are just two brief comments, and I hope that the group and the section will take this forward.
Well, thank you very much.
Thank you.
Great comments, and I think we should start implementing them. I just would like to answer, just give final answer to your question. I think you're totally right. It's becoming technical. I think the overall goal of this technicalization is to help and actually to allow a more holistic approach. Right now, many of these studies are still experimental, but one day, if we have readily available imaging, if we have pharmacogenomics, if these things have shown some validity, you as a psychiatrist will be able to choose from that menu, and I think it will give you actually more time to apply your whole knowledge as a psychiatrist and to add, and it will free up time. So I think that's the promise, I think, that I see in this technicalization of psychiatry, as you put it. But I also maybe would like to thank all of you again for a great session. This has become now a staple of many meetings. Also thanks to Afzal and WPA for allowing this, and we are now really out of time. Thank you very much.
Award. Oh, there's an awards. There's awards for the speakers. You're getting awards. Yeah. Oh, okay. Yeah. Sorry. Okay. Professor Despande. Oh, it's fantastic. Yeah. So now Marcela Richard, Marcela, you also get something? Professor Fernando Goes here, is here? Yes. And there's more. Ich gebe wieder kein Sprecher. And this is for Professor Maha. And now, there the last two are coming. Professor Hamid and Professor Rose. Hamid, Alhad, here. Dr. Rose, let's here. I'll take the final picture. Great. Go there and take it. Okay, good. Okay, good. I'm not getting okay. Now
Oh my goodness. They say this is a good sign. That this is so good. The evil is gone.
Is the round?
Oh yes, yeah, we are ready. I'm new to genetics, you know, I was a psychiatrist, but you know, I'm driven.
تعال تفضل دكتور طارق. Hello, Assalamu alaikum. Good morning, everybody. My name is Dr. Moses Sabusi. I'm the chair of Behavioral Sciences Institute in Al Ain Hospital, which is part of Al Ain region, that is the eastern region of Abu Dhabi. So today I'm really delighted to chair the session and introduce Professor Tariq Qasim. So, Prof. Tariq, he's a consultant in old age psychiatry, and he's a lead for all the adult clinical academic group under Mosley Health, which is in Al Amal Hospital. Also, he's adjunct clinical professor of psychiatry at Mohammed bin Rashid University of Medicine and Health Sciences in Dubai, UAE, and also he is honorary consultant in old age psychiatry at South London and Mosley NHS Foundation Trust, London, UK. Prof. Qasim obtained his certificate of completion of training CCT in old age psychiatry from the UK and holds a master's degree in neurology and psychiatry and a bachelor degree of medicine and surgery from Ain Shams University in Cairo. He also received a part of his training at the National Hospital for Neurology and Neurosurgery, Queen Square, the UK's largest dedicated neurological and neurosurgical hospital. Prof. Qasim has published extensively in high-impact academic journals. He has received several awards for his contribution to psychiatry, including the Fellowship of the Royal College of Psychiatrists in 2019 and the UAE Innovates Award for an innovative project utilizing the artificial intelligence for early detection of dementia in 2022. He was also awarded the American College for Health Executives Excellence Institutional Gold Award in 2022 for his leadership and management of specialized mental health services for older adults in the UAE. In addition to his clinical practice and research, Professor Qasim has developed the training program for addiction, clinical practice, and old age psychiatry, including the first multidisciplinary master degree in addiction clinical practice in the Arabic world. He has co-developed the Arab Fellowship in Old Age Psychiatry. This is under the Arab Board qualification. And his expertise in the field of dementia has led to his appointment as an expert member on several national committees and bodies for dementia. He is also a referee for several high-impact journals, including British Journal of Psychiatry and British Journal of Psychiatry Open. So welcome, Prof. Tariq. Today, the subject will be a very interesting one. تفضل دكتور. The subject will be beyond the blues, apathy as a critical factor in mental health recovery, and this topic is very interesting for me, and it has memories, actually, old memories. Just to mention a short story before you start, Prof. Tariq. In my very first week in psychiatry residency, in my very first on-call, my very first patient, actually, I was called to see a patient who was in her 40s, married with children, and the ED physician, he asked me to come and see the patient as a case of depression. So I came to see the patient. She seems to be retarded. They say that she's depressed, but I'm not sure. I mean, I wasn't experienced. I mean, my first on call. Okay, they are saying she's depressed, but I had a feeling it doesn't look like a depression. So, and also what was also in her history that she received ECT in another hospital. So everybody was pushing me to admit her. I admitted her. I remember I admitted her to the surgical unit because we didn't have a bed in the psychiatric unit, and she was retarded. The nurses, they accepted her. The next morning, I asked my consultant to come and see her. And interestingly, he picked up the sign from the first 15 minutes. He asked for urgent CT. And unfortunately, she had like a very large astrocytoma in her brain. So that was my very first case in psychiatry, case of apathy. And I've never forget this case. I hope I didn't miss anyone after that. And I found it very interesting, really. And I believe many psychiatrists, they tend to, misdiagnose apathy. So I'm very much interested to hear from you today. Thank you very much, Prof.
Bismillah ar-Rahman ar-Rahim. Thank you very much, everyone. Thank you for attending. Thank you for inviting me to this conference. And thank you, Dr. Moza, for the very kind and generous introduction. Yeah, it's difficult. It's difficult to differentiate apathy from depression. They look alike. And I'm sure I've made that mistake before, just mistaking apathy for depression. And the reason why I'm presenting this case is because Dr. Walid, who's a consultant working with us, we just had an admission, I think a month ago, kind of 6 weeks ago, with a person with quote-unquote resistant depression, and he did not have depression. It was an extreme apathy because of when we investigated him, we found that he had undiagnosed SLE that caused strokes and other things. Okay, so that's me. So these are the learning objectives. So understand the definitions, prevalence, differences between apathy and depression, identify the similarities and differences, learn about assessment tools, and get knowledge about pharmacological and non-pharmacological treatment, and able to recognize causes, manifestations, as well as coping strategies that could happen with apathy along with depression and when they coexist. Okay, I don't have any disclaimers to make. I haven't received any honoraria. I don't know if you can get that. So that was or is a poll. It's about really your knowledge. Can't you hear me? Can you hear me? Okay. Tamam. This is a poll, or it was a poll. I'm not sure if it works or not. But if it's not, can it be? If it is going, this. Is it working? تمام. ممتاز. Thank you. So from the memory, if the memory serves me well, no. So the first question is about historical figure that has a saying associated with apathy. This saying has resulted in his or her losing his life. Do you know that figure? Yeah, what did you say? Let them eat cake, yeah. But, well, that's what we were told. It was a true. So that's an extreme kind of callosity and indifference to other people's emotions. If they don't have bread to eat, let them eat cake. Okay. It's not working. Okay. Maybe it's working with you. It's not working with us. So the other question is about is apathy an integral part of depression or not? How much you agree or disagree on this? So could apathy happen on its own or mostly happen within a context of depression? Or could depression happen without apathy? So that's from memory. And the third question is about how to manage a person who's presenting with apathy, medication-wise. It's just a pool of opinion and to see how people manage those things. Okay. So talk a little bit about apathy. So apathy is a motivational disorder. It's lack of motivation, manifested as diminished interest or enthusiasm, and reduced emotional responsiveness. Okay. Individuals with apathy has difficulty in initiating and sustaining activities or seem indifferent to other people's emotion as well as their surroundings. So that's basically the definition of apathy, and there are research criteria for diagnosis of apathy. While depression, we have diagnostic criteria for depression. You know it, so depressed mood as indicated by sadness, hopelessness, helplessness, worthlessness, tearfulness, okay, or diminished interest, so the person needs to have one or two, and most of the time of the day, most of the days of the week, then they need to fulfill at least 4 from the other 9 criteria. But who cares? The question is, who cares for the difference? By the way, the screen does not correspond to here. So that's a case I'm trying to make to differentiate both. So apathy could happen as a standalone. I see it as a standalone without depression. I'll tell you why we separate them. Or because I work in older adult psychiatry, so I am an older adult psychiatrist. So I see them a lot in neurocognitive disorders or dementias, okay, without depression. However, depression is a mood disorder that could happen primarily as a functional disorder or could happen secondary to other medical disorders. Prognosis is quite different when a person has depression or apathy. So if a person has apathy and they score, for example, an apathy evaluation scale, 1 standard deviation more than the average, the prognosis is really poor. So their death is double their comparator. 1 standard deviation more equals double death in 18 months. Also, apathy predates the other symptoms of dementia by 10-15 years. It's mostly the first symptom to start before the cognitive symptoms, independent of the cognitive symptoms and predictor of the cognitive symptoms. Also, dealing with apathy reduced the risk of mortality, risk of being admitted to long-term facility, risk of deterioration of general health in general. Depression could happen during the illness at the start with a diagnosis or later, but it doesn't have that progressive course of an illness. It doesn't work. Okay. So from the phenomenological point of view, depression is a mood disorder. So there is the very qualitative, distinctive feeling of sadness. So there is no depression according to the criteria. So either profound sadness, hopelessness, helplessness, worthlessness, or tearfulness, or lost interest / anhedonia. But there is this distinctive inner experience of being sad or miserable. In apathy, it's mostly motivation. So the person does not have motivation. When we ask them clinically, are you sad? Absolutely not. Do you think that life is not worth living? No. Do you think about death? No. That's not the answer. People mistaking them from the outside because they don't do much, psychomotor retarded, or maybe they must be depressed, but when we ask them about how they feel, their answer is, no, they are not sad or hopeless or helpless. Don't think about suicide. No. The neuroanatomical circuits are completely different. And also, as we mentioned with apathy, the person really is indifferent. They don't care. And they don't care that they don't care even. So they are sitting in front of a telly. They're fine as long as people do not disturb them, or even if they disturb them, they are fine with it. So the major thing is indifference. So it has this ego dystonic. They are at peace with their symptom. Syntonic, I mean. While depression, people really try hard to change their state of affair, whether by getting treatment or ending their life because their life is unbearable. And the response to treatment. So we know that there's something called SSRI-induced apathy. So patients are not apathetic, and the percentage is different, but it's quoted between 25% up to, in some of the literature, 90%. SSRI-induced apathy. And when we prescribe patients with apathy SSRIs, if they don't improve, mostly they are going to get worse. It doesn't work, it makes them worse, while in depression, SSRIs mostly work. So these are my arguments why it's important for us to differentiate both, because they are totally different syndromes. Yes, apathy could happen within depression, but if there is no depression, then it's a totally different illness with totally different entity completely. Okay, so these are the prevalences. So it's mostly with the neurodegenerative diseases, but we also see it with depression, we see it with chronic psychosis. And we see it a lot with frontotemporal dementia and vascular dementia, especially the small vessel disease. What's common? So the fatigue, lethargy, lack of initiation, that's common. Lack of interest, that's common. Social withdrawal, that's common. Negative impacts on overall quality of life. These are common things. Key differences. So we mentioned that earlier. So the person who has apathy, it's a lack of. He's not interested, he is indifferent. They don't feel sad or anything. They just at peace with what they have. Problem mostly is initiation or sustaining any activities, and that include, they don't have any negative thoughts or thoughts about death if we're talking about apathy as an entity of its own. When we ask them, do you think about death? The answer usually is no. Suicide, the answer is usually no. And we mentioned that treatment, they respond differently, especially to the SSRIs. So these are the diagnostic criteria from the consensus group. This is specific to neurocognitive disorders. So primary diagnosis of neurocognitive disorder or dementia. So this is the first criterion. The second criterion, or the second set of criteria, is at least 2 out of 3 for 4 weeks. Difference in performance or behavior from the person pre-morbid personality or behavior. The first one is behavioral. So B1 is behavioral criterion, which is loss of initiation or maintenance of any activities. And that has two components, those who are interested. So loss of initiation of chores, things that are routine or kind of boring, and loss and initiation of anything pleasurable or hobby-like, so things that the person used to like before. Well, that's the first. The second thing, B2, is cognitive. So the first criterion is behavior, the second criterion is set of criteria is cognitive. Apathy, which means that the person is no longer curious about the environment they are in. So any change in the environment does not invoke their curiosity to change. If there's conversation, they wouldn't engage with it. And the third set of criteria is emotional responsiveness. They don't care in general, and hence they don't care about what people feel. It's not that they are callous. They don't care about anything. Hence, when people are sad or happy, it's the same for them. And that's where that loss of emotional spontaneity as well as loss of emotional reactivity comes from. And all of them, so need to have 2 or 3, and those causes significant impairment or distress, and not exclusively due to substance or any other thing similar. That was it. That was study done in East Anglia, Cambridge. So these are this profile of symptoms for people who have depression. So we see the sadness, so crying, act depressed, feels failure, bad person, the person feels bad, they feel that there is no future, feeling burden, and that happens a lot with the elderly, wanting to die, wish to die, okay, and other signs. The other, so this is the depression. Okay. The other, the apathy is the red one. So loss of interest, failing conversation, they're not interested in conversation, failing emotional responsiveness, sitting quietly. Mostly when I do home visits, those people sit in front of the telly, and they sit from the morning until the evening doing nothing. Mostly they smoke, and sometimes there could be food stains on them or smoke burns on their attire, and they're fine. Okay. I'll talk a little bit about assessment tools. I'll mention the apathy evaluation scale. So that's specifically for apathy evaluation. Sorry. And the geriatric depression scale, we have geriatric depression scale 30, 15, and 7. And we use this in our services NPI, or neuropsychiatric inventory, which is quite comprehensive. It has a set of questions for depression and another set of questions for apathy. They are different. There is minimum overlap, but they are different. And the correlation between questions are not high. So, for example, does the subject in depression, does the subject have periods of tearfulness? So, again, an expression of sadness. Does he or she appear sad or in low-spirited, put himself down, seem discouraged? So these are the questions in depression. While in apathy, he seemed less spontaneous, less initiative in the conversation, lacking emotional responsiveness, and the rest. And they can discriminate patient. Time? Oops. So that's an analogy. So an apathetic person is like a car who's run out of fuel, while a depressed person is a person who's stuck in the mud trying to get out. So these are the neuroanatomical correlates. They are quite different. Just I want to say a couple of things about especially this. So auto-activation deficit. There are several types of apathy. This one is interesting because the person could appear, so no activity whatsoever if they are left to their own devices. However, they are very responsive to environmental stimulation. So once we ask them to do something, they can do. that. And that could get spouses especially very unhappy. So they think that they are unhappy in the relationship. It's not about that. They are environmentally dependent on stimulation. And we can use this for treatment. Not going to mention this. We talked about differences, treatment, because this is important. So we mentioned that SSRIs mostly do not work. Anti-Parkinsonian especially prove dopaminergic, but not bupropion. So the meta-analysis says that bupropion do not work. Okay, so amantadine, there is evidence that amantadine work. D-agonists, they tend to work. Stimulants, they tend to work. Cholinesterase inhibitors, so that's for Alzheimer, they tend to work on apathy. Agomelatine, so this is an antidepressant, it reduces apathy. Modafinil could reduce apathy, but we don't have it. Atomoxetine could reduce significantly apathy in a subset of patients who have severe atrophy and locus coeruleus, but that needs specific investigation. So these are the medications that have evidence behind them. I have a patient who has been sitting, he was a diplomat, he was sitting on a chair for 4 years, he was prescribed 2 antidepressants. I was asked to go and see him at home. I went and saw him at home. He was sitting in front of a telly with ashtray full of cigarettes, with cigarettes burned, and the family insisted that he was depressed and antidepressant do not work, and they wanted to up the dose, and educated them, working with them, stopped the antidepressant completely, started him on cholinesterase inhibitors, rivastigmine, and another D-agonist. He's a totally different person. To a degree, and that was really startling for me, to a degree that he started to have vocal tics. Vocal tics, sometimes he may say obscenity, but very mild occasionally. And I discussed with them that I would like to reduce or stop. And he and his family said no. People, when they come out of the apathy, they know how bad they were. And they were very keen not to stop the treatment. So these are non-pharmacological treatments. They work, so these things work. But I just want to add one thing. So habit is important because for us to do things, we either depend on our motivation, and apathy is a motivational disorder. Hence, once the action is repeated several times, we shift from a motivational-based action to a habit-based action. Hence, the person could start do a routine work. We can employ hygiene, personal hygiene. If we set the time right, the stimulus right, people acquire that habit. The other thing, let's do it technique. So rather than I ask, would you like to? So would you like to come? No, it's not like that. So let's go. When I ask a person with apathy, would you like? So these are two things. I'm asking him to choose. So that's one. The second thing, to employ his decision after choosing into a motor. So when let's do it. That helps people a lot. Usually, our clients, when patients come with apathy, are the caregiver. So they're very distressed about it. Patients are not too distressed about it. It's the caregiver who are distressed. And part of what we do is we give caregiver support. We try to teach them how to build routine into their lives. And the other thing is, if they suffer because of the degree of stress, if they suffer from mental health issues, we refer them to general adult psychiatry. Some of our colleagues from general adult psychiatry receive some of the spouses, younger spouses, or daughters and sons of our patients, try to separate our role from supporting them as caregivers from doctors for the parents. So basically the summary, not sure about time, but basically about summary, it's depression and apathy are totally different concepts. They could overlap, but the treatment is different, the prognosis is different. They need attention. They may be difficult to assess and treat. We need to work with the caregiver. We need to work with the patient. The armamentum of medications are different. They have their own side effects, so we need to be aware of if we are going to prescribe. Non-pharmacological interventions could be effective. They need work. They need time to work, but could be very effective. And when people get out of apathy, they wouldn't like patients then. Their attitude changes. They don't want to go back to how they were. So that's a saying or analogy. So apathy is, the world is gray with no drive to chase the colors away, but while depression is, the world is blue, but they long to find brighter hues. So at least in depression, the person would like to get out of the state, while in apathy, they are fine staying as they are. And these are the references, and thank you very much.
السلام عليكم. بحب أنوه بس إن الجلسة باللغة العربية. For those who cannot speak Arabic or understand Arabic, it would be difficult for them. Okay, let's start. Okay. أنا الدكتور عفيف منصور، بروفيسور واستشاري الطب النفسي في مستشفى ميدي كلينيك شارع المطار. سعيدة ان انا النهارده موجودة في حاجة انا بحبها، المعنى الحقيقي للطب النفسي. مش عايزة اقول انسوا اللي اتقال، لانه الكيمستري مهم والجيناتكس مهمة، لكن مش عايزين نضيع قيمة الطب النفسي اللي هو مبني على الإنسان ومبني على مهاراتك كطبيب أو كمعالج نفسي. فأنا سعيدة النهاردة إن هنسمع 2 متميزين في العلاج النفسي، وهنبدأ بدكتورة زهرة الموسوي. أهلا وسهلا. دكتورة زهرة الموسوي من الكويت، حاصلة على درجة الدكتوراه في علم النفس، ولها العديد من المؤلفات في مجال علم النفس، وقدمت العديد من الورش في مجال الصحة النفسية وتربية الطفل والحياة الزوجية والعلاج النفسي. هتكلمنا النهاردة عن موضوع مهم جدا، أنا حقيقي سعيدة قوي إن هي هتتكلم فيه، عن التعرض لصدمة الحب وعلاقته بالإصابة بالاكتئاب. قبل ما نرحب بالدكتورة بالدكتورة زهرة، أكيد ما في حد منا ما شافش حالة جات له في العيادة إنه كان داخل في قصة حب معينة وفي النهاية فشلت لسبب من الأسباب، يا إما إن الطرف الآخر هو اللي سابه، أو إنه هو نفسه لقى إن العلاقة مش مناسبة وحابب يطلع منها، وفي النهاية بيجد فيه صعوبة، يا إما إنه هو بيفكر كتير في الموضوع، يا إما إنه مش قادر يطلع منه، في النهاية حياته بتتأثر. فخلينا نسمع من الدكتورة زهرة في الموضوع ده إزاي هنتعامل. اتفضلي يا دكتورة.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أشكركم لحضور ورقة العمل اللي راح أقدمها اليوم، والموضوع أتوقع أنه شوية interesting وحساس، سواء موضوع الحب أو موضوع صدمة الحب. اثنينهم من المواضيع الحساسة اللي غالبا مثل ما قالت الدكتورة نادر منا، خصوصا في مجال العمل في سواء العلاج النفسي أو الطب النفسي أو الاستشارات، ما واجهنا أشخاص يعانون من هذا الشيء، أو أن أغلبنا أصلا مرينا بهذه التجربة. فاللي راح أقدمه اليوم راح يكون في هذا المجال. طبعا موضوع الحب من المواضيع القديمة جدا، يعني هو ليس موضوع جديد، وليس أحيانا يتصورون أن الحب بدأ في هذا العصر أو في في الأزمنة المتأخرة، لكن تقريبا يعني من الآثار اللي حصلوا عليها من قبل 4000 سنة وجدوا أن البشر كتبوا في هذا الموضوع. وتدرون أن حرب طروادة أيضا من الأمور اللي صارت بسبب علاقة حب، وراحت ضحية هذه العلاقة آلاف من الأشخاص. فالموضوع هذا موضوع مهم وقديم، لكن الغريب في هذا الموضوع أن في مجال علم النفس الدراسات على هذا الموضوع أقل من المجال اللي عملوا فيه في الأدب والفن وإلى آخره. يعني تقريبا ما في مسلسل، ما في فيلم ما يكون الحب جزء أساسي منه، ما في رواية، ما في قصة، ما في شاعر ما تكلم عن الحب والمشاعر اللي موجودة. لكن لو تروحون تشوفون تبحثون، يعني أنا لأن كنت بسوي هذا البحث فرحت بحثت بالعربي بالإنجليزي عن الدراسات اللي صايرة عن الحب، وعن سواء الحب أو اللوز أو الفقدان، اللي أنا هني استخدمت مصطلح صدمة الحب. الدراسات في هذا الموضوع قليلة. ليش الإنسان يحب؟ ليش الإنسان يواجه هذه الآثار السلبية الشديدة في حال فقدان موضوع الحب؟ فنحتاج إذا إحنا في هذا المجال نركز نص التركيز اللي صاير في مجال الأدب والفن، يمكن نقدر نطلع بنتائج فعلا مفيدة للبشر. وطبعا اليوم راح يكون بس الموضوع تقريبا شرح لورقة العمل، لكن إن شاء الله إذا الله أحيانا في المؤتمر القادم تكون الورشة اللي بقدمها عن الحب والفقدان. طبعا هذه الورشة المفروض إنها موضوع الحب والفقدان لازم نقدم الورشة في الجامعات والمدارس اللي هم معرضين أكثر، لكن مثل ما راح تشوفون في النتائج موضوع الحب وصدمة الحب ما تنحصر بفئة المراهقين والشباب. ليش اخترت كلمة صدمة الحب؟ هذه مو من اختراعي. الدكتور روز في 1999 هو كان سايكاتريست ويعمل على الأشخاص المصابين بالPTSD نتيجة حرب الخليج. فبما أن تركيزه كان على الPTSD وكذا، تدرون أن لما الإنسان يشتغل على شيء تفكيره يصير على هذه الأعراض وكذا. فبعدين بعد ما خلص، لما شاف في العيادة الأشخاص اللي يعانون من صدمة الحب أو يعانون من الفقدان، خلينا نقول للحين ما كان مسميها لاف تروما، اللي يعانون من الفقدان يواجهون أعراض مشابهة للأعراض اللي شافها عند الجنود اللي تعرضوا للPTSD. فلذلك سمى موضوع فقدان يعني موضوع البارتنر. طبعا الفقدان اللي نقصده هني غالبا، وحتى في العينة اللي عندي ما نقصد الفقدان بسبب الموت، لأن هذا موضوع يكون مختلف. غالبا يكون بسبب يعني انتهاء العلاقة، الحين بأسباب مختلفة راح أذكرها لاحقا. فشاف أن هؤلاء الأشخاص يعانون من أعراض مشابهة، مثلا مثل ما تعرفون من أعراض الPTSD أن الشخص يتذكر باستمرار الحدث اللي تعرض له. نفس الشيء الشخص اللي يكون عنده تعرض لفقدان موضوع الحب باستمرار، دائما هذه كلمتهم، من أفتح عيني لما أغمض عيني أنا قاعد أفكر في هذا الشخص، وحتى لما أنام أحلم فيه. فباستمرار هذا الشيء لما يروحون أماكن يعني مثلا لو توصونهم مثلا إنه طيب خلاص طلعي، طبعا ما يخص إذا أنا الحين أذكر ضمير المؤنث لأن العدد الأكثر هم الإناث، لكن اللاف تروما ما تخص الإناث فقط. وعينتي أيضا الإناث فقط لأن العدد أكبر، لكن يعني كان عندي أشخاص راجعوا لي من الذكور وأيضا يعانون من نفس الأعراض، لكن مثل ما قلت لأن العدد أكثر فالتركيز يكون عليهم. فإذا مثلا إذا توصينهم إنه أوكي طلعي مثلا روحي كذا، تقول إذا أطلع أي مكان أتذكره، إذا أسمع أي موسيقى أتذكره، إذا أروح أي مكان أحبه أتذكره. فنفس الحالة اللي تصير في البي تي اس دي، اللي الشخص باستمرار لما يروح في الأماكن هذه يتذكر مثلا الحدث اللي تعرض له. طيب إذا هذا كان عن تعريف صدمة الحب أو اللاف تروما. أما الاكتئاب طبعا واضح وتعرفونه كلكم، أن مشاعر الانقباض والحزن والعجز واليأس ويعني المعايير اللي ممكن الشخص يتعرض لها. وغالبا طبعا احنا نركز على الأشخاص اللي صار عندهم الاكتئاب بعد التعرض لصدمة الحب، وليس أشخاص كانوا already عندهم حالة الاكتئاب. الأدوات اللي استخدمتها في هذه الدراسة، أول شيء كان مقياس الحب العشقي، يعني ميزته بالحب العشقي حتى يعني لأن تدرون إحنا واحدة من مشاكل الحب والدراسة على الحب أن هي كلمة واحدة تستخدم لحالات مختلفة. حتى في حالة الحب يعني مثلا إذا الشخص يقول أنا حزين الكل يعرف أنه يعني شنو، إذا الشخص يقول أنا فرحان الكل يعرف يعني شنو، لكن إذا الشخص يقول أنا أحب فلان أو أنا أحب فلانة، واضح يعني شنو؟ إيش رأيكم، واضح ولا مو واضح؟ نعم؟ إذن هو مع إنها emotions، مع إنها في الظاهر مشاعر، لكن غير واضح. مثل ما قالت الدكتورة، أولا على حسب فلان وفلان، وعلى حسب المشاعر هذه، وعلى حسب أن أساسا المشكلة اللي تصير في هذا الموضوع، اللي هذا ما راح أتطرق له كثير لأن الوقت ضيق، وهذا إن شاء الله مثل ما قلت في إذا الله أحيانا في الورشة راح أتكلم عنها إذا صار. الحالة اللي الشخص يسميها حب ممكن يكون لها أسامي مختلفة، مو بس أسامي مختلفة، هي حالات عاطفية مختلفة أو مشاعر مختلفة. مثل شنو؟ العشق هي الحالة الأخيرة، لذلك أنا سميت الحب العشقي لأن إحنا تركيزنا على هذه الحالة، يعني حالة شنو نقول، خلينا نقول إن الحب الرومانسي أو لاف أو رومانتيك لاف، اللي مثلا بالترجمات اللي الحالة الشديدة من الحب. لكن لما الشخص يقول حب ممكن يقصد إعجاب، ممكن يقصد إعجاب، وهذا الإعجاب ممكن ينتهي بمجرد ما تصير العلاقة أقرب. لكن هو في البداية كان يتصور أن إحساسه حب، وألقى للطرف الآخر بأن هذا الإحساس حب. بعدين لما صارت الارتباط أكثر واكتشفوا بعض أكثر، راح هذا الإعجاب وراحت هذه المشاعر. لكن ممكن الطرف الآخر لا، الطرف الآخر عدى مرحلة الإعجاب، دخل مرحلة الحب. فالحين المشكلة وين؟ المشكلة أن أولا الشخص ممكن يكون عنده مشاعر مختلفة كلهم يسميهم حب. المشكلة الثانية أن هذه في طرفين، الطرف الآخر أيضا ممكن يمر في مشاعر مختلفة ويسميها حب، ومو يعني مو شرط أن كلهم يمرون في نفس المشاعر في وقت واحد. فهذه الكومبليكيتد اللي موجود في هذه العملية تخلي أن هذه الحالة صعبة. زائد أن بسبب سهولة التواصل مع الجنس الآخر في الوقت الحالي، سواء في العمل أو بعد السوشيال ميديا، سهلت هذا الموضوع بشكل جدا كبير. يعني صار الوصول للجنس الآخر أسهل من الطلب من مطعم. فزادت هذه الحالات وزادت هذه الصدمات، وهذه الصدمات مثل ما راح تشوفون لها آثار جدا سلبية. يعني الشخص اللي يمر في هذه، أولا يتصورون أنه أوكي أول شيء صداقة وعادي وما فيها شيء وكذا، وفجأة يكتشف أو تكتشف أن هي صارت في علاقة حب. طيب هذاك الحين مو في هذه المرحلة، فيواجه هذه الصدمة. الحين لما واجه هذه الصدمة خصوصا إذا كانوا زملاء في العمل، الحين تصير المشكلة أكبر. طيب كل يوم راح تشوفه، الحين شنو أسوي؟ أطلع من العمل، أستمر، أتكلم معه، أكون عادية. فلذلك هذا الشيء اللي لازم نفهمه ونستوعبه، أنه هذا الموضوع يكلف الإنسان ثمن جدا غالي. فهذا كله قلته عشان أشرح كلمة الحب العشقي. ففي هذه الدراسة عملت مقياس الحب العشقي حتى أقدر أحدد أن الأشخاص العينة شدة الحب اللي كانوا يواجهونه في يعني لما قمت بهذه الدراسة. طبعا أغلبهم كانوا من مراجعيني، سواء المراجعين الجلسات الحضورية أو الأونلاين. المقياس الثاني اللي عملته كان مقياس متلازمة صدمة الحب، اللي في هذا المقياس يعني كانت هذه الايتمز موجوده. اول شيء الوسواس الاجتراري حول فقدان المحبوب، مثل ما قلت، لانه يصير عندهم مثل رومينيشن تجاه هذا الشخص، هذا كان يحبني ولا ما يحبني، هذا للحين يحبني ولا لا، احاول ان ارجعه، شنو اسوي، انا شنو سويت، انا غلطانه. ساعه يكون في حاله لوم، ساعه غضب، ساعه اخطط للانتقام. فبالنهاية طول الوقت في نوع من الرومينيشن. أيضا من الآيتمز اللي قستها في المقياس سلوكيات المراقبة والتطفل، اللي أيضا هي من الأعراض اللي موجودة لدى الشخص اللي يعاني من صدمة الحب، وممكن تكون عند الرجال حتى أكثر، مثلا مراقبة بيت هذا الشخص، وين راحت، هل هي داخلة في علاقة مع شخص آخر ولا لا. وأيضا نفس الشيء ممكن عند النساء، وخصوصا هم مع وسائل التواصل. مثلا واحدة تقول أن أنا يمكن باليوم 100 مرة أدخل في حسابه، أشوفه هو شنو حط، أشوف الستاتس ماله. طيب هو مو كل لحظة ممكن يغير، لكن هي مو قادرة كل لحظة تدخل في، يعني هذه السلوكيات تصير مثل سلوكيات وسواسية لمراقبة هذا الشخص، أنه شنو كتب، شنو حطه، شنو مثلا شنو معنى هذا الستاتس اللي حطه، شنو الستوري اللي حطه، شنو معناه، يقصدني أنا، لا معناته أنه هو للحين يحبني، لا هو قاعد يكتب كذي، لا هو كاتب مثلا كذا. فهذه السلوكيات هي أيضا من الأشياء اللي تأخذ من وقت وطاقة الشخص. رقم 3 السلوكيات الاجتنابية، مثل عدم الذهاب إلى العمل، عدم الذهاب إلى الأعراس، عدم الذهاب إلى يعني ممارسة الأشياء اللي تفرح، يجتنب الشخص هذه الأمور. سلوكيات إجبارية مثل ما قلت، مثل مثلا تتبع حسابات الشخص، وتداخل الصدمة مع الحياة اليومية، بحيث أن إذا هي طالبة ممكن ما تروح الكلية، إذا هي موظفة ممكن ما تروح الدوام، أو هو يعني أنا مثل ما قلت ضمير المؤنث ما يعني أنه فقط للإناث. والأعراض الاكتئابية والأعراض الجسدية اللي ممكن تصير مثل صداع، على حسب استعداد الشخص لأي مرض مثل الصداع أو آلام في الجهاز الهضمي وإلى آخره. الشخص ممكن يروح الطبيب وما يلقى حل، لأن أساساً المشكلة سايكوسوماتيك. وأيضا استخدمت مقياس بيك للاكتئاب اللي عربه عبد الخالق والنيال، وصار الصدق والثبات على العينة الكويتية بواسطة الأنصاري. عينة الدراسة اللي قمت بها تتكون من 50 امرأة، تتراوح أعمارهن بين 18 إلى 48. لذلك أركز مرة ثانية أن هذه الأعراض لا تنحصر فقط في الشباب والمراهقين. طبعا هني في هذه العينة انحصرت ل 48 سنة، لكن في العيادة عندي الأشخاص اللي عمرهم متجاوز 50 وال60 حتى، ويعانون يمكن حتى أشد من أعراض المراهقين. لأن الشباب ممكن يفكرون أن أنا عندي فرصة مرة ثانية أدخل في علاقة حب، لكن اللي صار عمرها 50 و60 وكانت في هذه العلاقة تحس أن بعد ما عندي فرصة مرة ثانية أنا أجرب وأدخل في علاقة مثل هذه. طبعا هم أوضح نقطة أن العينة ما تشمل الحالات اللي يعانون من مثلا الاكتئاب أو كذا بعد الطلاق ولا بعد الوفاة، هي فقط تشمل حالات علاقة الحب، إما فقط علاقة حب أو زواج بالسر. لأن اللي يصير زواج بالسر تقريبا يعني هو يعني مشابه لهذه الحالة، ما نقدر نسميها زواج مثل الزواج، مثل الأمور اللي تترتب على الزواج بشكل طبيعي، فتكون مثل حالة حب لكن شرعية. يعني فالعينة تشمل هذه الأشخاص اللي كانوا في علاقة حب فقط بدون زواج أو زواج بالسر، وانتهت يعني صدمة الحب صارت بسبب انتهاء العلاقة وليس بسبب وفاة الشخص. الصدمة الكبيرة اللي كانت في هذه العينة أنه واضح تقريبا العدد يعني الأكبر أو 64% كانوا غير متزوجين، و7 أشخاص أو 14% كانوا مطلقات، لكن 11 شخص أو 22% كانوا متزوجات. بعضهم كانت مثلا هي أساسا تحب شخص وهذا الشخص ما كان مناسب، كان من دولة ثانية، كان مثلا كذا، ما قدروا يتزوجون، تزوجت شخص آخر الآن مثلا 10 سنين أو أكثر، صار لها متزوجة عندها أبناء، لكن مو قادرة تنسى هذاك الشخص، وبين فترة وفترة ترجع له، هذاك هم الحين متزوج وعنده أبناء وهي متزوجة وعندها أبناء، لكن كل فترة مرة ثانية يرجعون يتواصلون يرتبطون، ومو قادرة إنها تحب زوجها ولا قادرة إنها تنسى هذا الشخص. وبعضهم للأسف صار علاقة يعني هي متزوجة ودخلت في علاقة مع شخص آخر، وطبعا هي تدري أن الآن هي مجبرة أن تترك هذا الشخص لأن هي متزوجة، وهي أصلا مو ناوية أنها تنفصل عشان تتزوجه، وتدري أنه هو شخص غير مناسب، لكن فهذا كل هذا الوضع تجبرها على أن تطلع من هذه العلاقة فتواجه صدمة الحب أو هذه الأعراض. مستوى التعليم تقريبا كلهم كانوا من المستوى الثانوية فما فوق، يعني ما عندنا أقل من الثانوية. المهنة مهن مختلفة، أغلبهم موظفين، بس 3 كانوا ربات بيوت، أو 3 ربات بيوت و8 لا تعمل. التخصص الدراسي أيضا تخصصات مختلفة موجودة هني، ما نذكرها الحين بالتفاصيل. وأما النتائج راح تكون على النسب المئوية والتكرارات، وكذلك العلاقة الارتباطية. تقريبا 3 فقط من الأشخاص كانت علاقة الحب اللي عندهم حب عشقي بسيط، 24 حب عشقي متوسط، و23 حب شديد. طبعا درجة الشدة تحددها الدرجات اللي يحصلون عليها في المقياس. و5 فقط كانوا يعانون من صدمة الحب العشقي البسيطة، 23 متوسطة، و22 صدمة الحب عندهم شديدة، أيضا بسبب شدة الأعراض اللي يجاوبون عليها في المقياس. و12 شخص كانوا يعانون من اكتئاب بسيط، 9 اكتئاب متوسط، 20 اكتئاب شديد، و9 اكتئاب شديد جدا. النتائج الارتباطية مثل ما تشوفون تبين أن درجة ارتباطية جدا عالية بين الإصابة بصدمة الحب والأعراض الاكتئابية عند الشخص. يعني الشخص اللي يتعرض لصدمة الحب احتمال إصابته بالاكتئاب عالية جدا. وأما تحليلي من النتائج اللي حصلتها ومن مشاهداتي للمراجعين اللي يعانون من هذا الموضوع، أولا صدمة الحب مثل ما قلت تتكون ب3 أشكال، يا إما الطرف الآخر ينهي العلاقة ويقول لا والله أنا بطلع، أو هي تقول أن أنا ما أبي أستمر، أنا أبي أطلع وأنا أبي أتزوج، أنت ما راح تتقدم لي، أو ظروفك ما تسمح أو كذا، فأحد الأطراف يطلع من العلاقة، أو أن العلاقة أساساً تكون من طرف واحد، لكن هذا الشخص يتوهم أن هذا مثلا هذا قال لي كذا، إذا هو يحبني، هذا مثلا عمل لي كذا، مثلا زملاء في الدوام أو مثلا كذا، فهي تتوهم أن هي عايشة قصة حب، بعدين تتفاجأ أن فلان باكر زواجه، فتصاب بهذه الصدمة أن هي كل هذا الوقت كانت بانتظار أنه هو يتقدم لها أو يصرح لها بالحب، لكن تكتشف أن لا، هذا كلها كانت أوهام، أو أن لا، الاثنين ما زالوا في المشاعر تجاه بعض، لكن مثل ما قلت في ذيك الحالة الظروف تخليهم أن يكونون مضطرين ينهون هذه العلاقة، إما بسبب أن الأهل غير موافقين، أو أن هذا في دولة وهذيك في دولة، أو الظروف ما تسمح. فاثنيناتهم فعلا يحبون بعض ومتمسكين في بعض، لكن الظروف ما تسمح فينجبرون بأن يتركون بعض. واللي بين سواء من المقابلات معهم أو من المقاييس أن هذه العلاقة الآثار النفسية تكلفهم جدا تكلفة عالية. أيضا من الملاحظات اللي شفتها، معروف دائما، أنا ما أدري الحين هذه كلنا نقولها بس ما أدري هل لها دراسات أو كذا، أن الحب يستمر 6 أشهر. لكن اللي أنا شفته أنه لا، مثل ما قلت في أشخاص حتى مضى على علاقة، أولا كانوا في علاقة حب أكثر من 6 أشهر، يمكن 1 و2 سنين وما انتهت، وبعدين الآن ما زال 10 سنين وأكثر الشخص يعاني من هذه الأعراض. يعني تو قبل فترة واحدة مو من ضمن العينة، هذه هم من الأعمار الكبيرة، كانت تراجعني بسبب صدمة الحب، استمرت معها الأعراض 2 سنين. بعدين كانت كاتبت لي إن هي أرسلت لي رسالة، قالت أنا أبي أبشرك إن أخيرا أنا فجأة تخلصت من هذه الأعراض بعد 2 سنين. فمو بهذا الشكل أنا يلا خلينا ندخل في علاقة وصار ما صار، أو كلها مثلا شهر شهرين أنا أكون متضايقة وأطلع منها وأنا أكون متضايق. لا، في أشخاص حتى مثلا رجال كان في علاقة حب، بعدين مثلا الظروف ما سمحت، خلاص قال يلا أنا بنساها، راح تزوج، بمجرد ما تزوج هذيك رجعت له، خلاص الحين ما أقدر أنا أعيش مع زوجتي، أنا أوكي بديت أحب زوجتي بس بما أن هذه رجع حبي لها. أشخاص بعد 20 سنة، بعد 20 سنة اللي كان يحبها تطلقت، الحين يحاول أنه يرجع لها بعد 20 سنة مع وجود أطفال ومع كذا، والزوجة خلاص فكرت أنه مثلا هذا نسى حب القديم وهو الحين يحبها، فتتفاجأ وتنصدم أنه لا، هذا 20 سنة كان يحب هذيك والحين صار الفرصة يبي يرجع لها. إذن الموضوع ما ينتهي بهذه السهولة. مثل ما قلت هذه الصدمة ممكن تحصل لأي عمر، ما في أي عمر محدد، لذلك كلنا لازم نكون حذرين إن ما نقع في علاقة ممكن تكلفنا آثار نفسية أو ثمن نفسي كبير. من مشاهداتي اللي شاهدتها أن الشخص اللي يواجه صدمة الحب يشبه حالة الطفل اللي ضايع في السوق، شلون يصرخ ويدور وما يعرف شنو يسوي. وغالبا يقولون لي أنا مستغربة من نفسي، أنا مو كذي، أنا أصلا مو من النوع اللي أحط حياتي على شخص، أنا شنو صاير لي، أنا ليش صايرة كذي، أنا يعني بسهولة إذا شخص مثلا ما يناسبني أو مثلا كذا أو صديقة أو مدري هذا، أصلا الصديقات اللي يعرفون يقولون لي أنت شفيك، أنت ليش صايرة كذا. فالشخص يستغرب من نفسه وشلون تحول إلى طفل قاعد يدور على هذا الشخص ويبي يرجعه بأي ثمن. أكثر الأعراض اللي يعانون منها ويراجعوننا ليس الاكتئاب، مع أن مثل ما شفتوا علاقة الاكتئاب جدا عالية. الاكتئاب كأنه يقدرون يتحملونها، الشيء اللي ما يقدرون يتحملونه أو يحسون بأن هذا فوق طاقتهم هو الوسواس الاجتراري، مثل ما قلت التفكير المستمر بهذا الشخص اللي يخليهم ما يقدرون يمارسون حياتهم، والشعور الشديد بالوحدة. يعني غالبا هذا الشيء اللي يعانون منه. طيب هذا ما كان موجود قبل وهي كانت عايشة حياتها، لكن كأنه لما تصير علاقة حب غالبا شنو يقولون أنا كنت أكلمه من أبطل عيني لما أغمض عيني، أنام والتليفون بيدي وأنا أكلمه، الآن فجأة هذا الشخص اختفى. فتخيلوا كم الفراغ اللي يصير عند الشخص. مثل ما قلت قبل كانت عايشة حياتها عادي ما عندها مشكلة، بس الحين لأن فجوة كبيرة صارت، فالشعور بالوحدة تصير جدا فظيعة ما يقدرون يتحملونها. وأيضا التذكر المستمر في كل حدث صار، المشكلة هني، فإذا هي تبي تستمتع أصلا راح تتذكره، فكيف تستمتع عشان تطلع في حالة الاكتئاب العادية ممكن الشخص يحاول يقول أوكي لما أطلع مثلا شوية يقلل الاكتئاب هم زين، بس هذه حتى لو تسوي شيء تبي تستانس منه يرجعها للمشكلة. وهذه كانت أهم النتائج اللي توصلت لها، وشاكرا لكم حسن استماعكم. شكرا.
شكرا للدكتورة زهرة. طبعا هي عملت لنا تشويق. أعتقد إن هي عملت لنا تشويق وقدمت الجزء الأول، وبعد كده هتعمل الجزء الثاني نشوف كيفية التعامل مع المشكلة دي. بس حقيقي فعلا منطقة حساسة جدا، وأنا كطبيبة نفسية بشكر بشدة زملائي المعالجين النفسيين اللي هم السايكولوجيست، لأن هم دول زي ما بنقول الملاذ اللي لما بتقابلنا الحالات دي بنحولها عليهم عشان يقوموا معاهم بالواجب من ناحية الجلسات. الجلسات أتت بثمارها الحمد لله، إن لم يكن بيرجعونا الحالات مرة تانية. وزي ما قالت دكتورة زهرة، في بعض الأحيان بنتعامل معاهم على إنهم نوع من أنواع الOCD أو نوع من أنواع الديبريشن، وفي بعض الأحيان ممكن يصل الموضوع لحد الإدمان. وبتقابلنا حالات كتير زي كده فعلا، ربنا يكفينا شر إن الواحد يقع في حاجة زي كده، لأن هي بتبقى مدمرة. دلوقتي هنستقبل البروفيسورة فاطمة خليفة من المملكة العربية السعودية، أستاذ واستشاري علم النفس الإكلينيكي بكلية الآداب والعلوم الإنسانية بجامعة الملك عبد العزيز بجدة، حاصلة على جائزة التميز في النشر العلمي وجائزة أفضل مشرف علمي للدراسات العليا، محكم علمي لعدد من المجلات العلمية، ولها العديد من الأبحاث المنشورة في مختلف المجلات، ولها العديد من المؤلفات والكتب في علم النفس ومناهج البحث. وبرضو هتكلمنا في منطقة شائكة وحساسة ومربكة جدا، وهي البوردر لاين بيرسوناليتي أو الشخصية الحدية. ايه انواع العلاجات اللي ممكن نحتاجها في التعامل معاها؟ وواضح ان هي عامله لنا يعني الخلطه السحريه المكونه من الCBT الDBT والACT، فما شاء الله ربنا يوفقها ان شاء الله. فين أنا بعتذر، ده اللي هو موجود في كتيب المؤتمر. أحبطتيني، أنا كنت عايزة أسمع البوردر لاين بس ما يجاش حاجة، نسمع الانكزايتي برضه محتاجينها. اتفضلي يا دكتور. بعتذر لكم مرة تانية، أكيد أنتوا هتشوفوا في الكتيب اللي معاكم إن اللي مكتوب هو البوردر لاين، يبدو إن في آخر وقت ما لحقوش يغيروا. اتفضلي يا دكتور.
سعيدة جدا بوجودي معاكم النهاردة ومشاركتي في المؤتمر. في البداية طبعا بوجه الشكر لجميع القائمين على إدارة المؤتمر وإتاحة الفرصة ليا أن أكون معاكم النهاردة. بيبقى شرف كبير ليا المشاركة. في الحقيقة هي مش أول مرة، أنا شاركت على مدار أعوام متتالية في المؤتمر، وكنت حريصة جدا أن أنا أحضر، لأنه بصراحة بيمثل إضافة، ودايما من سنة للسنة بلاحظ إن في تطوير وفي يعني تقدم كبير جدا في إدارة المؤتمر وفي المشاركات اللي بتتم في المؤتمر. فأهلا بيكم، وإن شاء الله أكون معاكم النهاردة كده ونقدر نستفيد. عذرا على اللخبطة دي، بس هو بالفعل كانت المشاركة كانت موجودة، بس ده كانت النسخة القديمة وتم تعديلها إلى العلاج المعرفي السلوكي للقلق. طيب بتحرك كتير فاعذروني. اوكي، انا بس عايزه اظبط ده الاول علشان يبقى ايه. طيب مبدئيا كده يعني حاضر بحب ابدا الجزء اللي انا هشتغل عليه النهارده بسؤال ان شاء الله كده الاقي فيه عندكم رد، وهو هل كل انواع القلق بتحتاج علاج؟ بتحتاج سي بي تي؟ كل انواع القلق بتحتاج سي بي تي؟ طب اللي بيقول يقول لي ليه، واللي بيقول لا برضه يقول لي ليه. اتفضلي.
لا، في القلق المحمودي اللي هو يساعدنا على الانجاز الافضل.
طبيعي الامتحان. لا انا كده هقعد بقى.
لا ما تقعديش، بالعكس احنا جايين نتعلم منكم. ففي القلق المحمودي اللي هو يخلينا ننجز اكثر، نقدم اكثر، اللي هو طبيعي والمطلوب. وفي القلق المرضي طبعا اللي مثل ما تفضلتي حضرتك يراد له علاج.
طيب ممتاز، كويس جدا. اتفضلي يا دكتور.
لا انا كده هتكلم عن الجزء اللي هو خاص بالحاله المرضيه، ان طالما المريض جاي من العياده فانا بتعامل مع الجزء ده، يعني الجزء الطبيعي مش هتكلم عليه. لكن انا بفكر في الحالات الانكزايتي، ان لو الحاله مايلد بيقدر ان انا اخليها تبدا مع كل لانه اسلوب حياه.
ممتاز.
مش فكره ان انا حد علاج يضيع السيمتومز وخلاص، لكن لو المستوى عالي او السيمتومز كتيره او مؤثره على حياتها ساعتها حد علاج. وبرضه لازم العلاج السلوكي لانه
شيء اساسي
من العلاج لانه طويل المدى.
طيب ممتاز، كويس جدا. طيب معلش السؤال ده برضه له سؤال تاني. انا هعمل ايه لو انا قلقت قلق طبيعي، وهعمل ايه لو انا قلقت قلق مش طبيعي؟ يعني في موقف معين انا طالب رايح اختبار قلقت، تمام، وفي نفس الوقت او مثلا انا وقلقانه ان ولادي مثلا متاخرين جايين من المدرسه والمفروض ان هم متاخرين، او انا منتظره نتيجه اشعه او تحاليل معينه، او انا على وشك الانفصال مثلا، في مشاكل زوجيه او مشاكل اسريه وانا على وشك الانفصال. لو انا قلقت قلق طبيعي هعمل ايه في المواقف دي كلها كطالب او كزوجه او كمستثمر مثلا متوقع انه ممكن يكون عرضه للافلاس، او كشخص منتظر نتيجه اشعه وتحاليل؟ لو انا قلقان بشكل طبيعي هعمل ايه، ولو انا قلقان بشكل مش طبيعي ايه اللي هيحصل؟ اتفضلي.
قلق طبيعي you will be able to confront، لكن إذا كان عندك قلق مو طبيعي you will avoid.
طب خلينا نبقى أكثر تحديدا. لو أنا بقول مثلا مثال الطالب ده اللي قلقان عشان رايح اختبار، هيعمل إيه لو قلقان طبيعي، وهيعمل إيه لو قلقان مش طبيعي؟
القلق الطبيعي إنه راح يقدم الاختبار anyway، بس القلق اللي مو طبيعي ممكن يجيب يدرس ويقدم الاختبار.
هيجتهد، هيسهر، هيذاكر، هيلخص، هيحل اسئله. ده لو قلقان قلق طبيعي هيدخل الاختبار. طيب القلق في الحاله دي عمل له ايه؟
اعطاه دافع،
خلاه ينمو، خلاه يتطور، خلاه يجتهد. تمام. طب لو بقى وصل القلق معاه ان هو اصبح مش طبيعي في نفس الموقف، هيعمل ايه؟
بيكون عنده physical arousals بحيث انه ما راح يقدر انه يراجع، ما راح يقدر يدرس، وبعد ما راح يقدم الامتحان، راح he will avoid.
وممكن ايضا يروح الاختبار بس للاسف مش هيقدم الاختبار بصوره جيده.
بيصير عنده نومنس ما بيقدر يقدم.
القلق بالظبط، القلق والتوتر اللي بيحصل واللي موجود عنده ممكن يخليه يؤدي اداء غير جيد في الاختبار، فتكون النتيجه سلبيه. طيب انا هشتغل مع انهي فيهم؟ يعني لو انا هعمل سي بي تي هشتغل مع اي فيهم؟ انا في كل الحالات ممكن يجي لي العياده ويقول لي انا قلقان عشان انا عندي اختبار، وممكن يوصل هيجي لي برضه اللي هشتغل مع انهي فيهم. يعني الحاله هي جايه لي وبتقول لي ان انا قلقانه ومش عارفه اروح الاختبار، تمام؟ انا هشتغل مع اي فيهم؟ مع اي اعراض؟ ها مين اللي يحتاج مني برنامج؟ انا فيهم اللي يحتاج مني برنامج؟ اللي يحتاج مني تدخل ويحتاج مني ان انا اعمل معاه سي بي تي.
اللي يحتاج التدخل الشخص الاخر اللي تؤدي الى يعني تاثير في اداء الامتحان او حياته او
ممتاز، كويس جدا. ممتاز، كويس جدا.
الشخص الاول طالما جالس حتى ولو الانكزايتي عنده طبيعيه معناها ان هي على الماكسيمم، واني ويلي او اني تايم هينقل على الناحيه الثانيه.
تمام.
فبرضه ده هيحتاج مني التدخل.
هيحتاج مني تدخل ولكن على مستوى الارشاد او على مستوى مثلا او على، لكن مش هحتاج مني ان انا اعمل له برنامج علاجي ممكن يكون يكون مثلا من 10 15 جلسه محتاج تدخلات علاجيه مني، استخدم معاه مثلا فنيات وتقنيات العلاج المعرفي السلوكي للقلق. فممكن يكون الموضوع بسيط، وده بيحصل معانا كتير، وخصوصا بالنسبه للطلبه او بالنسبه للناس اللي منتظره مثلا نتيجه اشعه او تحاليل او على وشك انفصال او في مشاكل اسريه او زواجيه. فبيبقى الشكوى جايه، ولكن في بعض الاحوال بيكون الموضوع طبيعي، يعني بيكون الموضوع بسيط وما يحتاجش مني ان انا اعمل برنامج علاجي. علشان كده انا بدات الجزئيه دي، لان احنا في بعض الناس بتخلط ما بين القلق الحميد، القلق الطبيعي اللي احنا بنقول اصلا هو علامه بالنسبه لنا للصحه النفسيه. يعني انا لو ما قلقتش هبقى حد مش طبيعي. تخيلوا كده، تخيلوا، تعالوا مع بعض نتخيل ان انا مثلا رايحه اختبار، رايحه انترفيو، جايه النهارده اعمل الليكتشر دي وانا ما عنديش شويه قلق، او انا بطبق على نفسي، ايه اللي هيحصل؟ ولا هقرا ولا هراجع ولا هعمل ابديت للمعلومات اللي انا داخله بيها. بالعكس، ده بقى دافع وحافز بالنسبه لي ان انا انمو واتطور وابقى حريصه جدا ان انا اظهر بافضل صوره قدامكم وهكذا. وبالتالي احنا بنرفع في الموقف ده بالذات، رغم ان هو قلق، ولكن خلونا نقول ان احنا كده بنرفع له القبعه، بنشعر نحو هذا القلق اللي هو اسمه في الاول وفي الاخر قلق بنوع من الشكر والعرفان والامتنان، على اساس ان هو دفعني للتطوير، عمل لي بوش كده للنمو، عمل لي بوش ان انا ابقى حريصه ان انا اظهر بافضل مظهر قدام الاخرين. تمام؟ طيب خلونا نسال برضو سؤال مهم، القلق ده مرتبط بالماضي ولا مرتبط بالحاضر ولا مرتبط بالمستقبل؟ ها؟ يعني وانا قلقانه، انا قلقانه من ايه؟ من اللي هيحصل ولا من اللي حصل؟ ها؟ قلقانه، يعني معنى كده ان القلق في مشاعر هو مرتبط بتهديد في المستقبل. تمام؟ القلق ده كمان بيمثل تهديد بالنسبه لي، وبيأثر على نموي، وبيأثر على استقراري، وبيأثر على اتزاني العاطفي، وبيأثر على اتزاني الوجداني. طيب مؤقت ولا جديد؟ ها؟ يعني حدته هل هو مؤقت مرتبط بحاجه معينه ولا هو عام جنرال؟ طيب على حسب نوع القلق. خلونا نتفق مع بعض انه اذا هو مؤقت فبقى طبيعي، لانه هو مرتبط بموقف، ومجرد ما بيخلص الموقف ده خلاص القلق بيروح. تمام؟ في نفس الوقت كمان الشده والحده بالنسبه للاعراض بتنتهي بانتهاء الموقف، زي ما قلت كده، اختبار، لقاء، انترفيو، عمل، سفر. فمعنى كده ان الاعراض بتنتهي بانتهاء الموقف. لكن لو قلق اخر اللي احنا بنقول بقى عليه، مش اللي هو مش طبيعي، اللي احنا بنقول عليه القلق العصابي، بنقول عليه قلق يعني خلاص دخلنا في مرحله ان هو ما بقاش مرتبط بموقف معين، الحده والشده بتاعته بقت مرتفعه جدا. يعني لو جيت اطبق عليه مقياس للقلق او مقياس لاي نوع من انواع المقاييس، هلاقي الدرجه بتاعته مرتفعه، ممكن مثلا تبقى 8 من 10، 9 من 10. فبقى كده مش طبيعي، اللي احنا بنقول عليه القلق الايه؟ العصابي. الله ينور عليك. يبقى معنى كده ان القلق هو دايما مرتبط بمواقف في المستقبل. القلق على حسب شدته وحدته، واذا كان مؤقت او غير مؤقت، هو اللي بيحتاج مني تدخلات عن طريق الCBT عشان برضو يبقى مفيش غلط. وفي نفس الوقت كمان القلق العصابي ده ما بيوقفش عند حد معين، ده ممكن يتطور، يعني ممكن يوصل الى حاله من الذعر، الى حاله من البانيك اتاك، اللي هي للاسف الشديد لو استمرت لفتره طويله. الدكتور عفاف تشاركنا في حاجه زي كده، ممكن الانسان يعني يموت لو تعرض لاكتر مثلا من نص ساعه للبانيك اتاك، يعني ففيها خطوره بالنسبه للانسان. معايا؟ طيب سؤال مهم برضو، خلينا نقول كده، طبعا الكلام ده احنا اتفقنا فيه مع بعض. سؤال مهم جدا، وهو القلق ده يأثر على جانب واحد عند الإنسان؟ أعراضه، يعني عشان نعرف برضو احنا هنعالج ايه بالظبط في البرنامج العلاجي اللي احنا هنستخدمه بالCBT. هل بيؤثر على جانب واحد بس في الإنسان؟ ها ولا ايه؟ القلق ده بيشمل الشخص في ايه وايه وايه؟ ها؟ بيؤثر عليه جسمانيا؟ طيب زي ايه مثلا؟ يعني لو انا أصبت بالقلق ايه اللي ممكن يحصل؟ ده انا ممكن يحصل سرعه ضربات القلب، ممكن يحصل زياده في سرعه التنفس، ممكن مثلا في بعض الناس يحصل عندهم بحوث في العين، في بعض الناس الاعراض مختلفه، كل انسان فينا له نصيب شويه من الاعراض دي. ممكن حد مثلا يحصل له نوع من انواع العرق، يحصل له نوع من انواع التبرد، تلاقي كده اطرافه متبرده. بعض الاشخاص تلاقي مثلا عضلات الوجه بتتحرك لوحدها كده، مش عارف يعمل عليها كنترول، مش ده بيحصل؟ كل واحد فينا تلاقي فيه عرض معين لما القلق بيزيد عنده ممكن يحصل الاعراض دي. حد تاني مثلا ممكن يحصل تصلب كده في العضلات بتاعه الرقبه. يعني كل متفقين على حاجه زي كده. طيب عضويا بس وجسمانيا بس؟ ها يعني القلق بيأثر على الفرد عضويا وجسمانيا بس؟ ها احنا بنتكلم عن CBT، لسه كنا مع دكتور ريهام كنا بنقول ايه ولا نسيته؟ معارف ومعلومات، يعني افكار معايا، وفي نفس الوقت وجدان شعور، وفي نفس الوقت في ايه؟ سلوك. يعني تذكروا بقى معايا عشان نربط كده. فلازم على الجانب العضوي متفقين ان هيبقى فيه اعراض. على الجانب المعرفي تعالوا بقى نشوف كده على الجانب اللي هو الشعوري، طبعا في خوف وفي توجس، ده احنا بنقول انكزايتي قلق، ففي خوف وفي توجس. وعلى الجانب التفكير خدي بقى حدثي ولا حرج، في عندنا مجموعه من الاعراض، في تعميمات سلبيه، في افكار آلية سلبيه، في افكار لا عقلانيه. لو تذكرنا في المحاضره اللي قبل، عندنا افكار آلية سلبيه، عندنا افكار لا عقلانيه، عندنا في تعميم للخبرات اللي هي السيئه. ودايما الانسان وهو قلقان تلاقيه بيتوقع الشر، تلاقيه متوقع ان ممكن تحصل حاجه هو مش خارجه عن ارادته. فدايما بيكون الاعراض بتاعته ايضا على مستوى التفكير. طيب لو احنا سالنا سؤال مهم برضه يا جماعه، انا القلق ده وراثي؟ القلق ده وراثي ولا القلق ده مكتسب ومتعلم من البيئه اللي الانسان بيعيش فيها، ولا هو خليط ما بين الاثنين؟ ولا ممكن الانسان لما يتعرض كتير لستريسفول لايف ايفنتس، احداث حياتيه صادمه، او مثلا خبرات صادمه زي مثلا التروما بتاع الحب، ممكن يصاب بالقلق؟ ولا هو خليط من الثلاثه دول؟ يعني احنا متفقين انه ممكن يكون في جوانب وراثيه، ولكن خلونا نوضح الجانب الوراثي ده، لان هو بيكون استعداد او تهيؤ وراثي، ومش المقصود بيه ان هو وراثي. يعني ايه؟ يعني لو انا، خلينا اوضحها برضو الجزئيه دي بالذات عشان ما يبقاش فيه خلط، انه لو انا عندي استعداد وراثي لده، بس البيئه اللي انا موجود فيها وفرت لي الجو اللي يساعدني ان الوراثه تاثر عليا، فانا ممكن ابقى قلقان. هديكم مثال بسيط خالص. انا والدي قلوق او والدتي قلوق، تمام؟ بس بتتعامل معايا بنوع من الود، بتتعامل معايا بنوع من الحب، بتتعامل معايا بنوع من الاحتواء، ما بتعليش صوتها عليا، ما بتتنرفزش عليا. اتوقع ان انا هكون ايه؟ قلوقه ولا غير قلوقه؟ رغم ان هي ايه؟ رغم ان هي قلق. فعشان كده بنقول الاستعداد او التهيؤ الوراثي بيتوقف على، وكانه كده شيء كامل، اذا دعت الظروف او البيئه المحيطه بالانسان واساليب المعامله الوالديه واساليب التنشئه الاسريه لو دعمته فخلاص هيظهر. ولكن في احتواء وفي حب، مفيش عدائيه، مفيش انفعال، مفيش غضب، مفيش زي ما الزميله تفضلت وقالت ابعدوا عني دلوقتي محدش يكلمني انا زهقانه انا فخلاص يبقى معناه ان هيبقى فيه نوع من الهدوء وفي التعامل مع الموضوع. طيب ايضا كمان التعلم الاجتماعي. طبعا النظريه السلوكيه واحنا بنتكلم في CBT بتقول انه اصلا مش بس السلوك الخاطئ، ده بتقول انه الاضطراب هو ممكن يكون ناتج لبعض الاساليب السلوكيه الخاطئه. يعني انا لو عملت استبدال في سلوك خاطئ انا اتعلمته، او في محاكاه لشخص انا قلدت سلوكه، لو انا استبدلت السلوك الخاطئ ده بسلوك صحيح، ودي بقى تكنيكات العلاج المعرفي السلوكي، لو انا استبدلت السلوك الخاطئ ده بسلوك صحيح فممكن المشكله تتحل. فعلشان كده بنقول لو في تعلم اجتماعي، شخصيه الابوين او في نموذج قدامي او قدوه قلقين، وبالتالي انا ممكن اتعلم ده منهم، بس يتوقف على ايضا البيئه المحيطه بالشخص. بالاضافه للصدمات الانفعاليه، كلنا لا ننكر ان الانسان دايما حتى لو هو شخصيه هادئه، ولكن على مستوى معين كانوا دايما يقولوا لي انت حد هادي قوي ودايما حكيمه في مواجهه المواقف، لكن لما بتتعرضي لستريسفول لايف ايفنتس، بتتعرضي لضغوط حياتيه مرتفعه على بشكل كبير ومتكرر ومش عارفه تاخدي نفسك، او زي ما بقول مش عارفه تاخدي كده ريست وترتاحي، فانت خلاص هتقلبي. يعني هاديه ايه بقى ومنفعله ايه وحكيمه ايه؟ لا، ده انت على طول بتلاقي نفسك بدات تتعصبي، بتواجه المواقف نوعا ما بطريقه مختلفه، وبدات شخصيتك اللي كانوا بيقولوا عليها هاديه ومش قلوقه لا هتبدا تتغير مع الوقت. تمام؟ يعني احنا كده متفقين ان في اعراض متداخله للقلق، وبرضه في اسباب متداخله لحدوث القلق. متفقين ولا مش متفقين؟ لان ده اللي هنبني عليه برنامجنا العلاج المعرفي السلوكي في علاج القلق. كل اللي احنا بنقوله ده هو اللي هيمشي عليه البرنامج العلاجي. طيب، مهم جدا نقاط اساسيه المفروض لما نيجي نبدا العلاج المعرفي السلوكي للقلق احنا نحطها في الاعتبار. اول حاجه زي ما اتفقنا كده في البدايه وانتم اتفقتوا معايا انه مش كل انواع القلق احنا عايزين ننهيها تماما. تخيلوا معايا كده لو انت ما عندكيش قلق في اي موقف من المواقف، بيقولوا عندنا كده باللغه المصريه ايه؟ بتبقي ايه؟ بارده، لوح تلج طالعه من الفريزر. بتلاقي نفسك اصلا يعني انت متاكد يا ابني انت عندك اختبار بكره؟ انت متاكده ان انت عندك انترفيو بكره وهيتوقف عليه اذا كنت هتشتغلي ولا مش هتشتغلي؟ انت متاكده ان انت مسافره بكره؟ بنقعد نسال كده احنا كأمهات. ليه؟ لانه اللي قدامي ما عندوش حتى ولو 2% ولا 3% من نسبه القلق. ففكره العلاج في القلق يعني لو احنا قلنا ان احنا بنقضي عليه تماما او بنتخلص منه تماما، دي فكره مش ظريفه اساسا. فنقطة مهمة جدا واحنا بنركز في علاجنا القلق ان احنا ما نلغيش القلق تماما. طيب، نقطة تانية كمان انه القلق بيصبح ضروري، ودي نقطة اساسية كمان، لما بيعوق الانسان عن التفاعل السليم. يعني تلاقوه كده ماشي يعني زي ما بيقولوا كده يخانق في خلق الله، دايما عمال يتوقع اشياء سلبيه، دايما منفعل، دايما متوتر، دايما متوقع الشر، دايما متوقع مش السيء، لا ده متوقع الأسوأ. فنبدا في العلاج لما نلاقي الانسان نوعا ما يعني ايه بيعوقه القلق ده عن التفاعل الطبيعي، عن التفاعل السليم في مواقف القلق المختلفه. نقطه مهمه جدا، ما ينفعش واحنا هنبدا نعالج القلق ان احنا نجتهد. عارفين يعني ايه نجتهد؟ كل واحد فينا كده يمشي باتجاه، ودي مشكله اصلا في العلاج النفسي او مع الاخصائيين النفسيين او المعالجين النفسيين. لا، هو مش اجتهاد، هو احنا لازم نشوف النظريات اللي اثبتت نجاحها والتكنيكات اللي اثبتت نجاحها بشكل عام في علاج الامراض النفسيه وبالذات في علاج القلق. زي ما يعني من شويه كده احنا بنتكلم على تكنيكات خاصه بالسي بي تي بشكل عام، لكن ايهما انجح في علاج القلق؟ ايهما انجح في علاج الدبريشن؟ ايهما انجح في علاج المشاكل الزوجيه او العلاقات اللي هي الاسريه او الخلافات اللي هي الاسريه؟ فاحنا مش بنجتهد، لا احنا بندور على الاساليب الاكثر فاعليه اللي اثبتت نجاحها في علاج القلق. كمان طبعا لا غنى عن العلاج الطبي، وده بيكون مفيد جدا جدا جدا، وده بيعتبر من اقدم واشهر انواع اللي هي العلاج، وبيكون كويس قوي قوي لما بيكون الشخص القلق ده هو عنده زياده في النشاطات الاستثاريه الانفعاليه الموجوده في الجهاز العصبي. لا ده احنا كده لازم على طول نحول على طول على السايكاتريست. يعني ما ينفعش ان احنا نقول بقى ايه الشخص ده احنا هنقعد نعمل معاه جلسه واثنين وثلاثه، فانت على طول اول ما بتلاقي فيه استثاره انفعاليه شديده في جانب اساسي لازم يحتاج لادويه، فاحنا لازم نحول للطبيب السايكاتريست. طيب طبعا عارفين يعني التحليل النفسي كان دايما لما نرجع لقديمه بقى كده يقولوا احنا لازم ندور على السبب. صح ولا غلط؟ طبيب النفس اول ما نقول تحليل النفسي نقول مين؟ فرويد كان بيقول ايه؟ كان بيقول ايه في التحليل النفسي كده لما بنيجي نعالج المدرسه التحليليه؟ لازم تقولي قبل ما تمشي ابحث عن اسباب الخبرات الصادمه في مرحله الطفوله، ابحث عن الخبرات الاساءه اللي حصلت في مرحله الطفوله. تمام؟ فلما عملوا دراسات على من خلال السي بي تي وجدوا ان ده بس مش كافي، يعني مش كافي ان انا ابحث عن الاسباب، ده انا لازم اركز على لازم اركز على ايه؟ على كل الاعراض، يعني جوانب عضويه، جوانب نفسيه متعلقه بالافكار، بالمعارف، بالسلوك، كل الامور دي انا لازم اركز عليها لما اجي اعمل برنامج علاجي معرفي سلوكي. طيب انا بقى هعمل ايه علشان يكون انسب علاج، علشان يكون العلاج بتاعي ناجح؟ انا لازم اركز على توتال، لازم اشمل كل الامور دي اللي هي الموقف اللي بيثير القلق. يعني في فرق بين انا قلقان عشان انا عندي امتحان، وفي فرق بين انا قلقان عشان هتطلق، وفي فرق بين انا عندي امتحان علشان انا متوقع ان ممكن يكون حاجه في الاشعه او التحاليل بتاعتي. كل هو موقف في الاساس هو قلق، لكن اللي بيثيره مختلف. صح ولا خطا؟ متفقين معايا في كده ولا لا؟ يعني في الاساس هو قلق، لكن بيختلف من موقف الى اخر. النقطة الثانية التعبيرات الانفعالية الغير سارة اللي بتحصل لما الإنسان بيتعرض للقلق، زي ما قلنا كده في ناس بيبقى عندها خوف، توجس، في عندنا جوانب فكرية وذهنية زي ما قلنا، ممكن يبقى فيه تعميم، ممكن يبقى فيه تخصيص، ممكن يبقى فيه أفكار آلية سلبية، أفكار لا عقلانية. ففي الحالة دهيت لازم أركز على ده في العلاج. يعني معنى كده ان العلاج النفسي الفعال لازم يخاطب الجوانب الاربعه دول، سواء اذا كان موقف، سواء اذا كان تعبيرات انفعاليه، سواء اذا كان الجوانب الفكريه، سواء اذا كان سلوك. طيب نبدا بقى ايه هي من اهم الاساليب اللي احنا بنستخدمها في علاج او التكنيكات الخاصه بالعلاج المعرفي السلوكي، اللي هي المواجهه. ما ينفعش كده يعني زي ما بيقولوا كده زي النعامه ارفس راسي في الرمل عشان انا بواجه موقف قلق. لما واجهنا الموقف بالتكنيك الخاص بالعلاج المعرفي اللي هو السلوكي، انا لازم اوجد حلول، لازم ابقى حاسه عن حل يساعدني ان انا اتغلب على موقف القلق ده. فعشان كده بنقول عندي تكنيك خاص بالمواجهه والتجرؤ وليس الانسحاب والهروب. وده بنستخدم معاه طريقه، وده هنطبقها في البرنامج في نهايه كلامنا ان شاء الله لو لينا وقت، اللي هو بنستخدم معاه اسلوب التعويض. هديكم مثال كده، او اسلوب المنهج المتدرج. انا بقول دلوقتي انا محاضر والمفروض لسه جديد، يعني لسه بادئ مثلا حياتي العمليه كده وهبدا اول محاضره، فانا قلقان جدا، معايا قلقان جدا. هو الجو حر ولا انا اللي حرانه ولا ايه؟ في حر. بدات كده امس كان تلج امس كان برد والنهارده حر. طيب الحمد لله طمنتوني عن نفسي. طيب خلونا نقول عشان انتوا اللي هتحددوا احنا المفروض هنعمل ايه علشان نواجه، ما ننسحبش، ما نخافش. في المرحله الاولانيه القلق هيبقى طبيعي زي ما اتفقنا كده، لكن لو انا ما عملتلوش عمليه مواجهه وعمليه ايجاد حلول فهو ممكن يبقى فيه نوع من انواع الانسحاب. ففي الحاله دي انا لازم اعمل تحديد، لازم اعمل منهج متدرج. فالمثال بيقول ايه وانتوا اللي هتعرفوني. انا دلوقتي بقول انا محاضر ولسه بادئ حياتي العمليه وداخل محاضره وقلقان ان انا ما اديش كويس. ايه المواقف اللي بتمثل بالنسبه للمحاضر ده قلق؟ زي ايه مثلا؟ المواجهه دي اول حاجه. يعني مثلا من قبلها باسبوع كده انا قلقان اصلا ان انا داخل المحاضره دي، اقلها تدريجا. طب لو علينا شويه هيقلق من ايه تاني؟ هيقلق المحاضر من ايه تاني؟ ممتاز، كويس جدا. هيخاف مثلا ان ممكن حد يقول له مجموعه من الاسئله وما يعرفش يرد عليها، مش ده وارد؟ لقيت مثلا زميل بيضحك، فانا ممكن يجي لي بعض الافكار ان الشخص ده ممكن بيضحك عليا وبيقلل مني، او انا ايه ده؟ وانا ممكن يكون انا يعني في حاجه غلط في شكلي. طيب ممكن يكون في حاجه مش مظبوطه فبيقلق منها، مش واقف واثق من نفسه حتى لو في حاجه غلط. واخدين بالنا؟ مش دي مواقف ممكن بتحصل؟ طيب نعمل ايه بقى؟ يعني احنا درجنا كده المواقف اللي بتقلق المحاضر دهوت من الاقل اثاره للقلق بالنسبه له، اللي هي من اول ما دخل قبل ما يدخل المحاضره بكام يوم لحد المواقف اللي هي هتثير قلقه داخل المحاضره. يتسال سؤال، حد يضحك، ازاي يواجه الموقف لو سال سؤال وما عرفش يجاوب عليه، ونبدا ندرج المواقف دي. هنعمل ايه؟ اتفضلي.
للمخاوف كلها او تدرج للمخاوف.
ممتاز.
وبعد ذلك نواجه نبتدي نواجه المواقف التدرج حتى يصير لها ريجريشن، تعرض الموقف او تعود على الموقف.
يعني لو قلت لك مثلا حطي لي 1 2 3 4 5، قولي لي بس رقم 1 1 2 3 4 5، ايه هي المخاوف من الاقل اثاره للقلق الى الاكثر اثاره للقلق في الموقف ده؟
مثلا
الخوف من الانتقاد ده اكثرهم. طب بس انا خايف اصلا ادخل المحاضره، انا اصلا خايف القاع واقف على الستيج كده، فدي بالنسبة لي
المواجهة، أول حاجة المواجهة.
لا المواقف نفسها، المواقف نفسها ايه؟ هندرجها كده من الاقل اثاره الى الاكثر اثاره. اول حاجه دخول القاعه. طيب ايه تاني؟ حاضر. ده قد ايه؟ والله؟ طيب خلونا نمشي سريعا علشان الوقت برضه، وانهي لكم الجزء الخاص بينا علشان الوقت برضه، اللي هو ببدا ادرج المواقف دهيت من الاقل اثاره الى الاكثر اثاره. من دخول المحاضره اخاف ان ممكن يحصل بعض اللي هي الاسئله، ممكن يوجه ليا بعض النقد، ما اعرفش اجاوب على سؤال معين، وبالتالي انا بعمل عمليه تدريب مستمر على الاستعداد للمحاضره والمواقف الاجتماعيه. ازاي لو اعمل علاقات اجتماعيه سهله مع الاخرين، ازاي اتعلم ان لو حصل موقف ما عرفتش ارد على السؤال ممكن اجله لنهايه المحاضره. عندي ايضا اسلوب الاسترخاء، وهو اكثر الاساليب اللي احنا بنستخدمها طبعا مع القلق، وفي نفس الوقت كمان يا سلام لو الاسترخاء ده بينفع معاه اسلوب اسمه التخيلات الذهنيه، او طبعا الاسترخاء اللي احنا بنطبقه هو استرخاء عضلي، وبنستخدم معاه اسلوب اخر اللي هو التخيلات اللي هي الذهنيه الهادئه. يعني نشغل معاه موسيقى هاديه واحنا بنعمل جلسات الريلاكسيشن، يتذكر موقف كويس مع اشخاص بيحبهم، مكان جميل هو كان بيروحه وبيهدى فيه وبيبعد فيه عن المشتتات والمشاكل. فدي برضو من التكنيكات الخاصه بالعلاج. نقطه مهمه جدا بقى عشان نعمل تعديل للافكار اللي عند الشخص ده، بعد اذنكم يعني عشان بس نكمل الجزئيه دي. بنعمل زي اللي هو تعديل للافكار. احنا عندنا العلاج المعرفي بيقوم على ان احنا في افكار آلية سلبيه وافكار لا عقلانيه. عارفه ان انا مش واخده بالي من الناحيه دي. فبنعمل ايه؟ الشخص اللي عنده قلق متوقع دايما انه الامور هتروح للاسوء. احنا لازم نزيده من الشعر بيت ونعمل له تعديل معرفي ان الافكار، الامور اللي انت بتفكر فيها كل ما هتفكر فيها بالطريقه دي هي هتزداد من السيء الى الاسوء. كل ما هتفكر فيها بنفس الطريقه. بنعمل له تعديل في الافكار انه لازم يعني بقدر الامكان تقنع نفسك ان انت الموقف ده هينتهي. يعني زي ما الدكتور كانت بتقول من شويه انه لا الحزن بيدوم ولا الفرح بيدوم، الامور متغيره، وبالتالي انت هيجي الموقف ده هيخلص. بالاضافه لحاجه زي كده انت كشخص لازم تتقبل انه الامور مش هتمشي دايما كده زي ما انت عايز، لا ده لازم تتقبل شويه من الضغط وشويه من القلق اللي انت بتعيش فيه. بعد كده بندربه دايما، عارفين بقى اللي هي طريقه زي ما بيقولوا كده بالشكل البسيط او البدائي اللي هي حديث المرايه. انا قلقانه من موقف هيحصل بكره، مثلا لنفرض ان انا هيتحقق معايا بكره في موقف معين في العمل، فانا لازم ادرب نفسي على الموقف ده، وكاني ماسكه مرايه كده وبكلم نفسي ايه اللي ممكن يحصل، انا غلطت في ايه، طيب واجباتي ايه، التزاماتي ايه ناحيه الموقف، انا اخطات في ايه، وفي نفس الوقت الاخرين اخطاوا معايا في ايه. فبنعمل زي تدريب كده على الحريه والتلقائيه الاجتماعيه، لانه معروف كده الانسان لما بيتحط في موقف قلق وكانه كده بيلغي عقله بيتلغي، وتيجي نفسك بعد شويه كده بنقول لنفسنا ايه، هو انا ليه ما عرفتش ارد؟ صح مش بنقول كده؟ هو انا ليه ما ردتش الرد ده؟ ما الرد ده حضر دلوقتي بس حضرش من شويه وانا كنت موجوده في الموقف، صح؟ فانا بدرب نفسي ازاي اواجه الموقف بقدر ما بحيث انه ابقى حاضره اجتماعيا وذهني حاضر في الموقف الاجتماعي اللي يستدعي القلق. كان انا بقول لنفسي كده هعمل ايه بكره؟ طب لو المدير سالني انت عملت كده ليه؟ طيب مين يعني كل الموقف الاجتماعي ده يكون حاضر في ذهني وابدا اجهز له بشكل كويس جدا. مش معناه ان انا اتجننت وبكلم نفسي، ولكن التدريب على موقف اجتماعي باسلوبه وبطريقته بيخليني اقدر اواجهه بشكل جيد. وفي نفس الوقت كمان اسلوب اخر اسمه تنطيق المشاعر. تنطيق المشاعر ده ان انا طول ما انا قلقان اعبر عن قلقي ده، يعني مشاعري، انفعالاتي، تعبيرات وجهي ما ينفعش تاني كاتم طول الوقت وتاني كل موقف انا قلقان منه حاطه كده جوايا وعمال اعبي جوه، هاجي في وقت كده ويحصل لي ايه؟ هنفجر. لكن كل ما يكون بعبر عن قلقي بافكار منطوقه بيكون سبب اساسي ومهم جدا ان انا اقدر اتغلب على القلق. طبعا الاطار العام للبرنامج سريعا كده، لو انا هعمل CBT للقلق المفروض ان هو بيشمل 3 مراحل. المرحله الاولى بتكون تمهيديه 3 جلسات بتعرف فيها على مشاكل العميل، بتعرف فيها على العميل وبشوف فيه اهم المشاكل اللي موجوده عنده، وفي نفس الوقت كمان بطبق معاه قياس مرتفع قلقي لازم اطبق معاه اختبارات للقلق. يعني اشوف القلق ده نسبته ايه عنده. عندنا مجموعه كبيره جدا من الاختبارات زي مثلا مقياس تيلور للقلق، مقياس سمة القلق لسبيربرجر، وعندي كوستو. دي من المقاييس المهمه في القلق. المرحله الثانيه وفي نفس الوقت بقيم علاقه علاجيه مع العميل، بالاضافه ان انا بعمل تحالف علاج. اما المرحله الثانيه بقى فبستخدم معاها كل التكنيكات اللي انا اتعلمتها في العلاج المعرفي السلوكي واللي تتناسب في علاج القلق، زي مثلا التثقيف، الاسترخاء العضلي، كل التكنيكات اللي احنا قلناها من شويه او خاصه بالعلاج المعرفي السلوكي ببدا اطبقها في المرحله دي. واخر حاجه عندي طبعا اللي هي المرحله الثالثه اللي هي اجراء التقييم النهائي. ببدا ارجع اعمل تاني زي تطبيق للاختبار، اشوف نسبه القلق، يا ترى البرنامج اللي انا عملته ده كان فعال، كان مجدي، خفض فعلا نسبه القلق ولا زي ما هي. وبعدين بعمل جلسات متابعه معايا. يبقى احنا كده بنستخدم 3 مراحل في البرنامج العلاجي، هي المرحله الاوليه او الاولى، وبعدين مرحله التدخلات العلاجيه، بالاضافه لمرحله انهاء العلاج المعرفي السلوكي. عذرا ان انا طولت شويه، وبشكركم على حسن الاستماع، وسعيده جدا بوجودي معاكم النهارده. اذا في طبعا اي استفسار هتلاقوه، بس طبعا بعد يعني
طبعا بنشكر دكتورة فاطمة ومن قبلها دكتورة زهرة. ولو في أي حد عنده استفسار سريع لأنه فعلا احنا عدينا الوقت. حد عايز يسأل أي سؤال؟ طيب الحمد لله إن الأمور كلها واضحة، وفي التوفيق دايما يا رب.
Thank you.